Bismillahirrahmanirrahim. Honorable Chief Guest, worthy speakers, respected seniors, ladies and gentlemen, Assalamu alaikum. On behalf of Department of Pediatrics, Foundation University Medical College, Fauji Foundation Hospital, Rawalpindi, I, Dr. Hajra Afzal, Resident Pediatrics, welcome you all to the Symposium on Challenges in the Management of Thalassemia. We will start today's proceeding with the recitation of few verses from Holy Quran.
अल्लाह के नाम से जो बड़ा मेहरबान निहायत रहम वाला है। कसम है ज़माने की। इंसान दर हकीकत बड़े खसारे में है। सिवाय उन लोगों के जो ईमान लाए और नेक अमल करते रहे और एक दूसरे को हक की नसीहत और सब्र की तलकीन करते रहे।
I request you all to please rise up for national anthem. The ongoing situation that has emerged due to COVID-19 pandemic has created challenges, especially in the field of medical education. In wake of surge of COVID-19, such educational activities were restricted to online sessions. By the grace of Allah, we have tried to fill this lag by conducting this workshop. The session is planned keeping in consideration all the COVID SOPs, including seating arrangements, hand sanitization, and masks. So, as we all know, thalassemia is the most common form of inherited anemia worldwide. Despite improvement in thalassemia care over the years, there still are many challenges. Such platforms give us the opportunity to learn from experts in the field. We hope that this knowledge will help us overcome different challenges in thalassemia care. We will now begin the formal session with a welcome address and overview of thalassemia by the head of Pediatric Department, Brigadier Professor Munir Akmal Lodhi, Sitara Imtiaz, military retired. He is the recipient of Presidential Certificate of Excellence for his services towards patients with thalassemia. Sir, I request you to please.
Bismillahirrahmanirrahim. It is a moment of extreme pleasure to welcome the guests who are present with us for this academic activity. On behalf of Pediatric Department, Foundation University Medical College and Hospital, I especially welcome the chief guest, Major General Imran Fazal, Halal Imtiaz Military, retired, Director, Foundation University, Principal and Dean, Foundation University Medical College. I am thankful to Major General Tasawwur Hussain, Halal Imtiaz Military, retired, who is Head of Medical Department and Associate Dean, Clinical Sciences. I also welcome Major General Maqbool, who is Head of Surgical Department. I am thankful to Professor Rai Asghar, who is President, Pakistan Pediatrics Association, Federal Chapter. I am thankful to Professor Jayakrishan. I am especially indebted to Professor Javeria Mannan, who is Chairperson, Thalassemia Federation of Pakistan, Professor Adil Akhtar, Professor Muhammad Naveed, who have traveled all the way from Lahore. Madam, without you, this would have not been possible. I am also thankful to Professor Nusrat Mushahid, who has joined us for her enlightened lecture on safe blood transfusion, which is very close to her heart. I am thankful to all galaxy of consultants, PGs, who are present here today. So I'll briefly touch about the thalassemia, its disease burden, challenges, and suggested way forward. We all know, this is for the juniors, there are many types of thalassemias, alpha thalassemia, beta thalassemia. Interestingly, alpha thalassemia are more common in Pakistan as compared to beta thalassemia. And beta thalassemia is again divided into beta plus, where there is some globin chain production, and beta zero thalassemia with almost no or severely impaired globin gene production, leading to hepatosplenomegaly, and they are prone to infections. Most of them will die in adolescence due to iron overload and different complications if not meticulously managed. Then thalassemia minor or trait, they are usually asymptomatic, but if they get married to a carrier, then the things are different. Very interesting part of thalassemia is thalassemia intermedia. It is actually a phenotypical diagnosis. Different genetic mutations can cause. So today we will be having a very informative talk how to diagnose and manage thalassemia intermedia. Because in my opinion, this is the thalassemia which is managed in improper manner in Pakistan. As we all know, if two carrier parents marry, 25% of children will suffer from thalassemia. 25% will be healthy, while 50% will carry the gene. This is just a slide for reminder for the juniors that the thalassemia major usually presents in first year of life, 6 months to 8 months, especially beta zero type, when there is a hemoglobin switch from fetal hemoglobin to adult hemoglobin, as the beta globin chains are not enough. So at that time they present with anemia, hepatosplenomegaly, CCF. And complications and treatment, they run hand in hand. And name any area, the iron overload affects the pituitary, parathyroid gland, hypoparathyroid gland, the gonads, pancreas, kidneys, liver and spleen, and all these complications take place. The management is basically divided into three. One is effective blood transfusion. Most of them, thalassemia major, are blood dependent. So we transfuse leuko-reduced, properly screened and cross-matched blood for them every 4 to 6 weeks. And then iron chelation is very important. As we are giving them blood, we are giving them 1 milligram of iron per ml of blood. As they have anemia, more iron is absorbed from the gut, and as ongoing hemolysis, iron overload is a very important parameter to be addressed. Then there are other supportive and curative treatment. Hematopoietic bone marrow transplant is the curative treatment with very good results due to change in the conditioning regimens. And then other like hemoglobin, fetal hemoglobin inducers like hydroxyurea, butarates, and in these days thalidomide has gained importance because many studies are ongoing about this, which I'll briefly touch later. Important to note, around 5% of the world population harbors at least one thalassemia allele. 80 to 90 million people are carrier worldwide. 68,000 annual births occur with thalassemia disorders of different variety. Among them, 23,000 are transfusion dependent. 80% affected children are born in low and middle income countries like Pakistan, India, Sri Lanka, and others. As many as 900,000 individuals with clinically significant disease are expected to come in the world in 21st century. These facts confirm that thalassemia are the most common inherited blood disorder in humans. Beta thalassemia is more common in Mediterranean countries such as Greece, Italy, and Spain. Cyprus has a carrier rate of 14%. Maldives has a carrier rate of around 18%. 1 in 49 marriages occur between carriers in Cyprus. 1 in 158 newborns are expected to have a beta thalassemia major variety. Conversely, alpha thalassemia is more common in Southeast Asia, India, Pakistan, Middle East, and Africa. Many mutations occur, but we do not find them, as most of them are clinically insignificant, as these genes are located on different chromosomes. So that is why the severity is not much. In our southeast region, around 1% pregnancies are at risk for one of the thalassemia variety. As you can see, we are in the endemic areas: Thailand, Vietnam, Cambodia, southern China, India, Sri Lanka, and Pakistan. We are in the endemic area for beta thalassemia, while it is transmitted by migration to other parts like Australia, North America, and South America. Worldwide, there are more than 400 mutations which can cause thalassemia. This chart shows different mutations which can occur. Many studies which were done in our part, especially in Pakistan, important mutations are IVS 1-5, frameshift 8-9, and frameshift 41-42. Then polymorphism is also important. Worldwide prevalence is around 6.6% are carriers. As you can see in Southeast Asia, it is highlighted around 6 to 8% is the average carrier rate in different countries and localities. Annual births, annual pregnancies which are at risk in our region is around 2 lakh. So 2 lakh pregnancies are at risk in Southeast Asia, which can have one or other variety of thalassemia. As you can see, in our region, Southeast Asia, around 20,000 children are born with thalassemia, out of which around more than 10,000 are transfusion dependent. And out of these, around 20% get proper transfusion and 19% proper chelation. Around 1,500 children in our region die annually due to iron overload, even if they are transfused regularly. In our country, 7,000 to 9,000 new children are born every year. A major chunk in Khyber Pakhtunkhwa and Balochistan, based on calculated estimates and gene frequency. It is roughly estimated that at one time, 120,000 children are there in Pakistan with this disorder. 9.8 million estimated carriers are present in Pakistan. It is safe to say that 25% or even more of all blood donations in Pakistan are consumed by these patients. Price burden is colossal. 10 billion rupees per year on management of thalassemia patients. One patient average cost on blood transfusion and chelation, if done properly, is around 300,000 to 500,000 per year. Cost of bone marrow transplant, which is curative, is average 3 million. So there are now governmental centers which are providing free treatment, but they are few. Uh, this was a study which was done to see the gene frequency. As I already mentioned, IVS 1-5, frame shift 41, 42, and frame shift 8 to 9 mutations were common in Pakistan. For the juniors, why it is important to know the mutations? Because if we know the mutations, we can do an extended family screening, and then certain mutations, they are amenable to certain types of treatment. This is a study, one of the authors is sitting here, Professor Adil Akhtar, in which they performed an extended family screening over 100 families who had one patient of thalassemia. And thalassemia major was found in 6% of the family members, intermedia around 2%, trait around 52%, and around 38% were normal. Everybody is trying to help these patients. Many centers like Children's Hospital Lahore, PIMS, NIBD Karachi, Fatmeed Foundation, Pakistan Thalassemia Welfare Society, Sundas Foundation, all of these are trying to help these patients. And you can see these are the last year registered patients with these, which are increasing every year. So what are the challenges? The burden is colossal. Prevention is still not in sight in near future. So we should have availability of adequate and safe blood transfusion. Adequate monitoring of regularly transfused patient is important. Periodic blood testing, prevention and uniform management of complications is very important to give them a normal and good quality of life. Imaging like DEXA scan, ultrasounds, echocardiography to see the cardiomyopathy is important. They need audiometry, ophthalmological examination, effective iron chelation, availability, cost and equipment, though has improved in last 5 years, but still remains a problem. Then there is lack of awareness about the psychological needs. Can you imagine of an adolescent who knows that he or she has to be transfused throughout his life, if not bone marrow is not done, and how they are seen in the peers, how they miss their schools every 3 or 1 day a month, and poor compliance by the patients and families even in areas where the treatment is free. Then lack of dedicated center of expertise, inadequate prevention programs, though some prevention programs are going, but still they are not creating an impact on the disease burden. So what is the way forward? We should have availability of adequate and safe blood transfusion because most of them will require lifelong transfusions. Establishing regional blood banks with special priority for thalassemia patients. National blood donation days. Provision of mandatory NAT screening facilities. As you know, NAT screening is very important to know even the minute amount of viruses so that they don't transmit hepatitis B and C. Because before NAT screening, which started in Pakistan in 90s, more than 40% of these children had one of these disorders. And it is very expensive. So it should be sponsored by the government. Leukoreduced and extended cross-matching should be done very early to prevent reactions and alloimmunization, which is a common problem in these children as we follow them in the years. Multidisciplinary centers of expertise requiring specially trained thalassemia physicians are still lacking. Hematologists with special interest are developing very fast. Then we should have reference lab, ultrasound, DEXA scan facilities, echocardiography to rule out cardiomyopathy, which is an important cause of death in these children. So availability of standard chelating drugs and equipment all the times, because many centers they are providing these drugs because off and on we have shortage of these equipment and medicines. Facilities for antenatal diagnostic and genetic counseling are developing fast, but still not according to the population. We should expand the number of centers performing hematopoietic stem cell transplantation. At present, a rough estimate is around 250 to 300 transplants can be done per year with HLA matched siblings and less intense pre-transplant preparatory preparations. Cure rate is very high. Genetic therapies are in pipeline with promising results which will completely change outlook in future, but we should all know that prevention is the key. So when we transfuse blood, we should maintain hemoglobin, which will give good tissue oxygenation, support the growth of individual, suppress ineffective erythropoiesis, hepatosplenomegaly, and other complications. But iron overload and complications can occur. Aluminization with hemolysis will remain a problem. BMT is potentially curative, but is cost prohibitive. In private setups, the cost is around 2 to 3 million, which is still very high, not freely available. Healthy matched sibling donors are required, and immunosuppression is required in these patients. Interest is being generated in fetal hemoglobin inducers, hydroxyurea and thalidomide. Hydroxyurea is an S-phase specific drug that reversibly inhibits ribonucleoside diphosphatase, leading to increased production of gamma globin chains, leading to increased formation of fetal hemoglobin. Thalidomide has been shown to increase hemoglobin F levels, and it has been used in various studies show that thalidomide in non-transfusion dependent and transfusion dependent thalassemia patients have shown variable but encouraging response to this medicine. More systematic studies are needed to assess efficacy and side effects profile, which can be very high. Luspatercept has now been used. It is like it has to be given subcutaneously. It is analog of erythropoietin, and it increases the maturity of the RBCs, and it decreases the transfusion requirements by around 50% in different studies. Thalidomide can cause neurotoxicity, weakness, headache. So these are the side effects by which we still think that it is still not a point of care, especially in transfusion dependent thalassemia. But I think in future it may be used in many centers. Screening and prevention, pre-implantation genetic diagnosis can be done. This technique has been developed for single gene disorders like thalassemia. Parents' fertilized eggs can be screened not only in context of thalassemia free embryo, but can also be HLA matching should be done with previous siblings. Free screening is available at many centers like Gangaram Hospital, Hayatabad Medical Complex, NIBD Karachi, and many NGOs are doing it at different levels. Though legislation have been done in Sindh and Balochistan for premarital screening, but non-implementation due to logistical issues is still a major problem. So community-wide preventive programs are important, awareness of physicians and community at-risk couples. After proper awareness and motivation, at-risk couples should undergo prenatal testing by CVS sampling at 10 to 12 weeks gestation, and depending upon their ethnic group, society, and their religious beliefs, they reserve their right to choose whether to continue or terminate pregnancy. For example, in Cyprus, Italy, and Greece, when couple has been informed that the fetus has thalassemia major, over 90% volunteered for termination. In Greece, an effective example of community programs, there were 3,500 patients with severe thalassemia who consumed around 1/4 of all the donated blood. Iron chelation therapy alone costed 7 million per year. After effective support and control program, these patients are using this support system, and very few new patients are born with thalassemia major. Similarly, in Cyprus, the birth rate have been for thalassemia patients have been reduced to negligible levels. So take-home message is, thalassemia syndromes are the most common genetic blood disorders with complex pathophysiology and serious multi-organ involvement. Early diagnosis, evidence, and guideline-based treatment can lead to long survival and good quality of life. A large number of thalassemia patients in our country lack access to quality and holistic care to multiple factors which needs to be addressed. There is a dire need to establish regional multidisciplinary centers of expertise for these patients. There is an urgent requirement for motivating and convincing healthcare policymakers to further enhance national preventive programs and make it more effective and sustainable. As survival and education is increasing in these patients, we need to move policymakers for allocation of special quota and jobs for them in public and private sectors according to their qualification. We suggest addition of thalassemia status in their ID cards, which will be done if made mandatory. Premarital screening has actually failed. Thank you very much.
Thank you, sir, for the comprehensive overview of the topic. Despite important advances in curative approaches, blood transfusion and iron chelation still remains the cornerstone of disease management. Our next speaker, Brigadier Dr. Nusrat Moshahid, Tamgai Imtiaz Military Retired, is consultant hematologist. She has specialized in the field of transfusion medicine and has trained many in the field. She is former Commandant Armed Forces Institute of Transfusion, currently working as CEO and consultant and technical consultant at First Solutions Rawalpindi. I request the worthy guest to please come on stage and enlighten us on the safe blood transfusion in chronically transfused patients. Thank you.
Bismillahirrahmanirrahim. Worthy chief guests, participants, my colleagues, juniors, seniors, assalamu alaikum, a very good morning. First of all, I want to thank the organizers for inviting me on this a very important topic symposium. I've chosen to speak in general terms, although I did ask Brigadier Munir to tell me whether I am going to focus on that. He said general sort of safety aspects of that. There are a lot of dimensions to safety in blood transfusion. And it is very closely, the pediatric and neonatal has further more broader dimensions to this safety. I'll touch upon them broadly and bring into focus the correlation, how the blood banking and the blood transfusion services need to gear up their systems and processes and goals and focus towards pediatric and neonatal transfusion if they're going to deal with one. This is a very neglected sort of aspect which most of the average blood banks don't know how to carry it out. As far as blood processes are concerned, broadly, it can be divided into starting with the collection, and then we process it to separate the component, and then testing is done mainly for transfusion transmitted infections. Obviously, before storage, they have to be properly labeled, and each component needs to be stored at a required temperature. That's why we separate them, so that they can have optimum shelf life. Otherwise, they will be compromised. And also we know that each and every component is not needed by every patient. So in order to optimize the resources, we need to separate them and store them at optimum temperatures of individual product. Then of course there's a mechanism by which the distribution of these products happen. And the best model so far, which has been successful world over, is when you have a supply system which is happens at a transfusion center, where all these activities, most of these activities are taking place up till here. And then these are shifted to a hospital blood bank, which are present within the premises of the hospitals. And the two activities that happen there are the cross-matching and issuance and hemovigilance. So that's the most optimal way of delivering the services, which leads to resource optimization as well as best management model accepted world over. We are also trying in the country to move around that, and so far with the German government help, 13 regional centers are to come up in the country. Out of these, 11 has been commissioned and the rest are being made, and these are supposed to run on ultimately collect the blood from volunteer donor services and supply them to the public sector hospitals. The management remains a challenge. इसीलिए उन्होंने अभी जो है पंजाब में कम से कम 2 सेंटर्स को, इंडस हॉस्पिटल को पंजाब ने पब्लिक प्राइवेट पार्टनरशिप में दे दिया है, बहावलपुर एंड मुल्तान. दे आर डूइंग द वर्क वेरी वेल. KPK is moving towards that direction, and let's see what happens to the federal area जिसमें recently उन्होंने commission किया है इसको. The blood which is collected in an anticoagulant, the anticoagulant which is used most commonly here with the blood bags is CPDA1, citrate phosphate dextrose. I've written the composition of this thing, and you can, when I'm going to go through the pediatric and neonatal physiology, you can see that these sort of anticoagulants would create a burden on an immature metabolic systems of neonates and pediatric. So that's why we need to be aware of these things, and sometimes the blood bank needs to do more than just an average issuance of the blood. The red cell storage lesions, these happens during this shelf life where the blood is stored within the blood bank at a 4 degrees centigrade with reference to red cells. So what happens is that the intracellular potassium goes out because of the depletion of the ATP pump, the sodium potassium pump that lies still for a while, so the potassium leaks outside. However, this although concerns for small volume babies, still if you look at the actually calculations, then approximately 75 to 100 millimoles, its absolute quantity comes out to be 5 to 7 millimoles in a red cell where the supernatant plasma has been reduced to less than or around 2 ml. This contains about 0.1 millimoles of potassium, and which if transfused at this dose and at this rate would not constitute a lot of burden. So it is important to know that, because this is a question which is frequently raised, but this depends upon amount of the plasma which is left there, which further lowers. If you have a more plasma there, the potassium concentration is further lower down. Also, the blood which is stored at blood bank has a reduced level of 2,3-DPG. 2,3-DPG is an ingredient chemical which is required to offload the oxygen to the tissues. तो जब 2,3-DPG जो है वो deplete हो जाता है, तो उसकी जो quantity है, this is the criteria for calling a blood fresh blood. Not the criteria कि अभी vein से लिया गया है, उसमें platelet भी है और plasma भी है और वो fresh blood है और whole blood की शक्ल में है. No. When we call fresh blood, what we mean is कि 2,3-DPG का लेवल जो है वो कम से कम 70 to 80% होना चाहिए. इसकी इम्पोर्टेंस ख़ास तौर पे न्यूनेट्स और पीडियाट्रिक्स में इसलिए है क्योंकि वो जो है वो उनके टिश्यू अगर डिप्राइव्ड है ऑक्सीजन के लिए तो यूजली दिस टेक्स 24 to 48 hours to restore. तो adult with chronic anemias can restore it, but those who are needed cardiac surgeries, shock, hemorrhage, massive hemorrhage, pediatric neonatal, they would need relatively already restored 2,3-DPG. तो इसलिए ये जो concept है fresh blood का ये certain settings में particularly neonatal setting में important है. That's why when you request, the blood banks should be able to give fresh blood based on this criteria. Red cell membrane changes also happens during this, and there's a decreased pH, there's decreased ATP level, there's increased lysophospholipid and also free hemoglobin. बट ये जो है क्राइटेरिया क्वालिटी का हमारा होता है ब्लड बैंक में वो ये होता है कि अगर हम कोई भी रेड सेल ट्रांसफ्यूज़ करें एट द एंड ऑफ द शेल्फ लाइफ 70% ऑफ द रेड सेल शुड बी एबल टू सर्वाइव इन वीवो. दैट इज़ द क्राइटेरिया. सो विद द करंट प्रैक्टिसेस जो हमारे पास अभी सिस्टम्स हैं, दिस क्राइटेरिया इज़ मेट. ओके, व्हेन वी ट्रांसफ्यूज़ रेड सेल इट इज़ लोडेड विद एलो एंटीजेंस. Blood transfusion is a type of a tissue transplant, and what we are transfusing, the alloantigens are in the form of one which are present on red cells. Mind you, about 300, more than 300 antigens are transfused and present, and out of 30 or more blood group systems. Platelets have their own antigen, white cells have the very important class 1 and class 2 antigens. Plasma has proteins and they are also antigenic, and they're preformed and later formed cytokines as well. So you can imagine the allo antigen load that is shifted or given to an individual patient with the transfusion. So I'll just allude to this pathophysiology a little bit, because that's a basis of one of a very important intervention which has a lot of impact for the future of those people who are going to be chronically transfused or those who are going to undergo transplant in future, whether it's a bone marrow transplant or is a solid organ transplant. What happens is that when blood is transfused, the one in which is not leukoreduced, which is not leukodepleted, उसमें क्या होता है कि جو پلیٹلیٹ سرفیس ہے اس کے اوپر تو مینلی کلاس 1 اینٹیجن ہے وچ از ناٹ گریٹلی امیونوجینک. however جو WBCs ہیں they are rich in class 2 antigens which are very immunogenic. اور وہ کیا کرتے ہیں, how do they act? There are two different mechanisms. One is called direct antigen presentation. What happens in this is that the antigen presenting cells of the donor which are present in the red cell in the form of monocytes and B cells and even other antigen presenting cells, they would present the class 2 antigen to the recipient T helper cells. اور یہ جو T helper cells ہیں they present these class 2 molecules جو کہ اس کے اوپر present ہوئے ہیں WBCs کے اوپر سے موجود تھے, وہ جو ہے وہ recipient کو جب present ہوتے ہیں تو they also stimulate the B cells which leads to proliferation and formation of memory cell as well and formation of anti-HLA antibody. اور یہ جو anti-HLA2 antibodies ہیں, these are responsible for many of the things which happen in a chronically transfused in the form of aluminization, febrile non-hemolytic transfusion reactions and other other effects as well. ایسا نہیں ہے کہ صرف جو ہے اینٹیجن کے جو ہے وہ اینٹیجن پریزنٹنگ سیلز جو ہیں وہ یہ کرتے ہیں. سم ٹائمس what happen is that these antigens are presented by recipient's own antigen presenting cells. So donor ke class 2 HLA antigens are taken up by the recipient APCs and they are presented to their respective T cells and then B cells are stimulated and the end result is the same. So what we have found out, it's the WBCs. So based on this, the people have done some interventions. Now before on to that, moving on to interventions, what happened is that the standard inventories جو ہم blood bank میں رکھتے ہیں وہ کیا ہے. We have red cells, we have a fresh frozen plasma and we have rendered donor platelets and cryoprecipitates. تو یہ usual standard products ہیں ایک اچھا blood bank جو ہے وہ deliver کر سکتا ہے. جو red cell ہم component prepare کرتے ہیں that is from adult donation, اس کا یہ volume ہوتا ہے which the hematocrit ranges between 0.6 to 0.7 depending upon کہ اس میں سے پلازما کتنا نکال دیا جاتا ہے. FFP یوزلی اس والیوم کی ہوتی ہے اور وہاں پہ کرائٹیریا یہ ہوتا ہے کہ کم از کم 70% سے زیادہ فیکٹر 8 ہونا چاہیے. اور جو رینڈم ڈونر پلیٹلیٹس ہے وی ایکسپیکٹ دیم کہ جی وہ ایک یونٹ میں اس کے اتنے جو ہیں وہ پلیٹلیٹس موجود ہوں گے. اور کرائیوپریسپیٹیٹ کا بھی کرائٹیریا جو ہے وہ فیکٹر 8 پہ ہے. سو اٹ از پاسبل کہ جو ہم پروڈکٹس بنا رہے ہیں ان کو ہم مینیپولیٹ کر کے ماڈیفائی کر کے اس کو کسٹمائز کر سکیں انڈیویجول پیشنٹ کی نیڈس کے مطابق. انڈیویجول پیشنٹ کی نیڈ کے مطابق جو پروڈکٹ چاہیے ہے اس کی بیک گراؤنڈ تو وی آر ٹاکنگ اباؤٹ از دا جاب اور ریکویسٹ فرام دا کلینیشینس. دا کلینیشین نیڈس ٹو بی اویئر کہ اس انڈیویجول پیشنٹ کی کیا ریکوائرمنٹ ہے اینڈ دیٹ ریکوائرمنٹ کو جو ہے وہ بلڈ بینک کے پاس بھیجنی چاہیے اور بلڈ بینک شوڈ بی ایبل ٹو میک دیٹ ریکوائرمنٹ, comply with that requirement. So the modifications that which are possible within the blood bank setting includes volume adjustments, hematocrit adjustments, pooling, washing, irradiation, liquid depletion, CMV tested, bacterial testing and pathogen reduced. یہ probably ہمارے پاس نہیں ہے ابھی, although Indus is working on that and they are very proudly saying کہ وہ AABB کی accreditation کرنے جا رہے ہیں تو اس کے لیے یہ کر رہے ہیں. But we even have not done simpler maneuvers جو کہ possible ہیں. یہاں پہ بھی ایک مس انڈرسٹینڈنگ رہتی ہے بٹ ہول بلڈ جو ہے دیٹ از اونلی, آئی گیٹ ویری فریکوینٹلی وی گیٹ ہول بلڈ ریکویسٹ. ہول بلڈ از اونلی, although it restores the volume as well as oxygen carrying capacity, لیکن اس کا جو ہے انڈیکیشن از اونلی پرابلی میسو ہیمریج. اور میسو ہیمریج کے لیے کیٹر کرنے کے لیے ونس ان اے وائل سینیریو کے لیے نو بلڈ بینک وڈ کیپ دیٹ. اس کا مطلب یہ ہوا ہے کہ اس سینیریو میں دا بلڈ بینک شوڈ بی ایبل ٹو ڈیلیور آل دا پروڈکٹس اینڈ دیز آر کالڈ میسو ٹرانسفیوژن پروٹوکالس. اور اس کا ایک طریقہ کار ہے اینڈ دس از اے اسٹینڈرڈ آف کیئر فار ٹراما پیشنٹ, میسو obstetrical hemorrhage اینڈ ادر سچویشنز. ریڈ سیل کنسنٹریٹ جو ہے دیٹ اونلی مینس دیٹ وی وانٹ ٹو ریسٹور آکسیجن کیرنگ کیپیسٹی. وی ڈونٹ ہیو اے وری اباؤٹ دا والیوم, وی آر ناٹ ٹاکنگ اباؤٹ بلیڈنگ اینڈ کوگولیشن پرابلم. We only want to restore the oxygen carrying capacity. So situations کیا ہوتی ہیں, acute and chronic anemia, loss of red cell. پلیٹلیٹس جو ہے وہ کوانٹیٹیو اور کوالٹیٹیو ڈیفیکٹس آف دا پلیٹلیٹس کو ٹریٹ کرنے کے لیے یوز کیا جاتا ہے اینڈ اٹس مینلی اے پرائمری ہیموسٹیسس ڈس آرڈر. پلازما which contains coagulation factors as well as anticoagulants and can restore blood volume and flow properties of the blood and some हमारे कम अज़ कम सेटअप में इज़ अ बिग सोर्स ऑफ एल्ब्यूमिन, क्योंकि एल्ब्यूमिन महंगी होती है तो इसलिए उसकी जगह प्लाज्मा इस्तेमाल कर लिया जाता है. क्रायोप्रेसिपिटेट इज़ रिच इन दीज फैक्टर्स. और जब हमारे पास कंसनट्रेट नहीं होते तो फैक्टर 8 हीमोफीलिया के लिए यूज़ किया जाता है. कौन सी सेटिंग है न्यूनेटल और पीडियाट्रिक ट्रांसफ्यूजन विच वी क्लिनिकली कम एनकाउंटर इज़ इंट्रायूट्राइन ट्रांसफ्यूजन. ऑल्दो वी हैव हार्डली एनी इन कंट्री जो कि इंट्रायूट्राइन ट्रांसफ्यूजन करें, स्टिल फीटोमेटर्नल जो मेडिसन है वो हमारी बहुत ही ना होने के बराबर है. एक्सचेंज ट्रांसफ्यूजन येस दीज फ्रीक्वेंटली हैपन्स इन ऑल दो सेटअप्स जहाँ पे न्यूनेटल यूनिट्स रन हो रही होती हैं. Anemia in infancy and children, which could be acute, chronic, transfusion-dependent anemias, which we are topic of today, perioperative anemias. Massive hemorrhages situations भी encounter करते हैं. Coagulation disorders, yes, also again common in pediatric and neonatal disorders, neonatal age में. So these are the settings where the transfusions are required of different components. And one big setting is a transplant setting, which is a very, very peculiar requirement. So why we need to focus and talk about the safety of blood transfusion in neonates and pediatrics? Because the children are vulnerable group with their special requirements, different from adults sometimes. And this is one of the most intensively transfused patients. They are likely to have long lifespan and post-transfusion, so adverse consequences को minimize करना makes lot of sense. It carries lot of value and investment and return on investment is much higher as compared to adults. You can see that as compared to adults where the median survival of 51 months, all patients receiving transfusion, they have a longer, they live longer. They will probably survive the event. They also, the special needs of children are usually overlooked by the blood banks and transfusion services. So it's important to create the awareness among the pediatrician and neonatologists so that they can create the pressure and ask the blood banks to gear up their systems and mechanisms so that they can deliver on that. You are the one who are going to create the demand and push the blood banks to do it so that they can cater for these needs. We know the peculiar physiology and anatomy. I think you are much more well versed than what I am, but what is relevant here is that we know that there's a transition to adult pulmonary circulation. There's a switching of fetal hemoglobin to the adult hemoglobin. Erythropoietin is low because of these reasons. Hemoglobin ranges are like this, and average blood volumes according to the weight is higher, and there's a rapid growth, so there's an increased blood volumes, and 2-3 DPG also gradually increases in these. So these are peculiar physiological changes that are happening. Similarly, the responses of neonates and pediatrics to hypovolemia, hypoxemia, and hypothermia are different from the adults. The systems are immature. Physiological responses are not as robust as adults. Metabolic processes are also immature because of so that has a decreased ability of liver to metabolize. Kidneys be immature, and so poor excretion of potassium acid and calcium. Parathyroid hormone response is also blunted in response to hypocalcemia. Their immature immune response, which predisposes them to certain things like complications like infections and other. Then serological status is very interesting and peculiar because we know all the antibodies that neonates mein hoti hain, they come from mother, and they are the IgG type. They don't have IgM. It's a fortunate thing which gives a flexibility to the blood banks. And that flexibility is often not used and exploited by the blood banks because they don't know. So when they don't have anti-A or anti-B formed until 4 months of age, so all antibodies are from those coming from mothers, and all these are mostly IgG antibodies. And unexpected allo antibodies are not found by the neonates. Any unexpected allo antibody will be the one which is coming from the mother. For example, anti-D. Anti-D in a D negative mother would be coming from her rather than child would not be making it. We know physiological anemia happens around this and then it recoups. So broadly spelling out the principles behind neonatal and pediatric transfusion, the consideration should be not only what is happening in the blood bank, but prior to that, and that is suitable transfusion triggers to ensure that appropriate use of blood and avoid harm. Rational use, I'm sure you must have seen all the guidelines جو pediatrics والے بھی جو ہیں وہ بناتے ہیں, hematologists بھی بناتے ہیں. Then alternative to transfusion and ways of reducing the need to transfuse, they should be explored. Wherever they can be implemented, they should be. Best blood products to use in view of physiology and setting, and what few considerations during the blood administration are also important. Because of these peculiar things that I've highlighted before, hum jo blood banking mein aur blood transfusion centers mein we tend to divide the blood transfusion practice into that which is in utero transfusion up to 4 months of age, including both the very low birth weight and extremely low birth weight, and older infants above 4 months, and then transfusion dependent anemias. So what is peculiar about 4 months, less than 4 months of age, that patients should be tested for both these ABO and RHD typing, and screening for alloantibodies either if plasma and serum is available from the neonate or from that of the mother. کیونکہ وہ بہت چھوٹا والیوم ہوتا ہے, بہت سیمپلنگ نہیں کرنی چاہیے, تو مدرز پلازما اینڈ سیرم از گڈ انف بیکاز وی نو واٹ ایور ایلو اینٹی باڈیز would be will be placentally shifted from mother. So that is why اگر سیرم اور پلازما بچے کا نہیں ہے تو مدر کا مانگا جاتا ہے. So during one hospitalization, cross-match compatibility and repeat ABO and D typing can be omitted provided antibody screening is negative, اور بلڈ بینک جو ہے اس نے پالیسی بنائی ہوئی ہے کہ سب کو گروپ او دینا ہے اور اے بی او کمپیٹیبل دینا ہے, اور اگر ٹرانسفیوز ریڈ سیل ڈی اینٹیجن نیگیٹو ہے یا ایون ڈی آئیڈینٹیکل ہے, سو دیٹ ول ریڈیوس دا سیمپلنگ اینڈ ری سیمپلنگ. سو اگر کلوز کوآرڈینیشن کمیونیکیشن ہے تو بہت, اگر بچے کو ریپیٹڈلی ٹاپ اپ یا کسی قسم کی ٹرانسفیوژن چاہیے تو دیٹ سیمپلنگ کین بی ریڈیوسڈ, اینڈ وی ڈونٹ نیڈ ٹو ڈو دا ریورس ٹائپنگ. مدر کی ایلو اینٹی باڈی جب آپ نے اسکرین کر لی دیٹس فائن. اب یہ جو ہے یہ جنرل پرنسپل بات کر رہی ہوں, مے بی سم بڈی از ٹاکنگ اباؤٹ اے بی او اینڈ آر ایچ ڈی جو ایلومنائزیشن ہے, دیٹ ہیمولیٹک ڈیزیز آف دا نیو بورن, دیٹ مے بی اے لٹل ڈفرنٹ اینڈ سینیریوز وڈ بی ڈفرنٹ. سم ٹائمز مدر از ناٹ اویلیبل. سو بلڈ پروڈکٹ مینیپولیشن جو نیونیٹس اور چلڈرن کے لیے سیفٹی کے لیے کی جاتی ہے وہ کیا کی جا سکتی ہے؟ بلڈ بینکس آر ایبل ٹو ڈو اٹ. ایلیکواٹ اسمال بلڈ والیومس ڈسپینسنگ, وی ہیو آپشنس, کوڈ بیگس, پینٹا بیگس, پیڈیاٹرک بیگس, سو دے کین بی یوزڈ انسٹیڈ آف پٹنگ دیم ان دا بیورٹ. اگر بیورٹ کی بجائے اٹ ول بی پریفریبل جو ڈیڈیکیٹڈ سرنج سیٹس ہوتے ہیں جس کے آگے فلٹر لگے ہوتے ہیں, بہت ایکسٹریملی لو برتھ ویٹ کے لیے جو ہے دیٹس ریئلی یوزفل. اینڈ دس از ون ویری ایکسپینسو پیس آف اکوپمنٹ. دا بلڈ بینکس اگر ان کے پاس نہیں ہے تو اٹ بیکمز ویری ہارڈ فار دیم ٹو گیو دا نیونیٹل اینڈ پیڈیاٹرک ٹرانسفیوژن دینا. دس یوزلی کاسٹ اباؤٹ 2.2 to 2.5 million, and the wafer that is used is now 400 to 500 rupees. I mean, the cost of doing business and cost of healthcare in our country has shot up tremendously with this rupee dollar thing. I'm talking because now I have my own setup. So وہ جو ہے بہت ساری چیزیں وائبل نہیں ہیں, اینڈ اٹس اے ویری انفارچونیٹ تھنگ کہ فرام ہیلتھ کیئر ویو پوائنٹ وی ہارڈلی پروڈیوس اینی تھنگ, نو پروڈکشن. تو اس کی وجہ سے کاسٹ جو ہے دیٹ از ہمنگس. Okay, so hematocrit reduction of donor exposure is one thing which is simple, but we do have a simple solution. When people ask me, so I do tell them کہ کیا کرنا ہے. وہ اگر کوئی blood banker یہاں پہ interested ہوگا تو I tell you, I think Seher might be here, so we talk frequently about that کہ ہم کیا کر سکتے ہیں اگر sterile connection نہیں ہے. There are ways to do it, we can do something. اور جو ہے donor exposure is important کیونکہ اینٹیجینک لوڈ بھی اس کا, ایلو اینٹیجنس کا لوڈ بھی جو ہے وہ تھوڑا سا کم ہو جاتا ہے ملٹیپل ڈونرس کے آنے کی بجائے, اینڈ سملرلی دا پرابیبلٹی آف ٹرانسفیوژن ٹرانسمیٹڈ انفیکشن بھی ہے تو اس میں بھی کم ہو جاتی ہے. تو یو کین ڈیڈیکیٹ دا یونٹس اف یو ہیو کیپٹ اٹ ان کوڈ بیگ, 4 بیگز والا بیگ یوز کریں اس کو اگر آپ کریں تو یو کین ایکچولی ریڈیوس دا ایکسپوجر. Hematocrit adjustments are very important for intrauterine exchange transfusion and as well as exchange transfusion later on. Volume reduce کیا جا سکتا ہے, supernatant remove کیا جا سکتا ہے, washing کی جا سکتی ہے. fresh blood کا میں نے آپ کو concept بتایا ہے کہ اگر 2-3 DPG ہے, requirement ہے peculiar, and also it should be a general policy کہ neonates اور pediatric میں particular neonates میں fresh blood دیا جائے. اریڈیشن کی کیا انڈیکیشن ہے اور لیوکو ڈپلیشن. سی ایم وی ٹیسٹڈ اینڈ لیڈ لیول ٹیسٹنگ جو ہے وہ بھی ابھی آج کل باہر والے کہہ رہے ہیں کہ برین ڈیمیج کرتا ہے, تو لیڈ لیولز جو ہیں وہ اس ایڈلٹ کے اگر آپ میئر کر لیں بلڈ پروڈکٹ میں, یا اس کو کم از کم لیبل کر لیں کہ یہ لیڈ جو ہے ان ٹیسٹڈ ہے. سو دیٹس اے پیڈیاٹرک بیگ ویئر یو کین ہیو اسمال ایلیکوڈس, اپ فرنٹ اس کو آپ رکھ سکتے ہیں, اور اس کا یہ بھی فائدہ ہے کہ آپ ڈیڈیکیٹ کر سکتے ہیں ایک نیونیٹ کے لیے تھرو آؤٹ دا شیلف لائف, اینڈ دیٹس واٹ آئی واز ٹاکنگ ود دا فلٹرس. سو یہ اس طرح کے پیڈیاٹرک بیگز جو ہیں وہ بھی کلیکشن کے وقت بھی آپ یوز کر سکتے ہیں. ہیماٹوکریٹ ایڈجسٹمنٹ ہمیں پتہ ہوتی ہے کہ ابھی ایوریج آئی ایم شیور موسٹ آف یو وڈ ناٹ نو کہ آپ کا بلڈ بینک کتنے ہیماٹوکریٹ کا بلڈ دے رہا ہے. یہ ہیماٹوکریٹ کی ویلیو اس لیے امپورٹنٹ ہے کیونکہ یہ جو ہے آپ نے کیلکولیشن جب کرنی ہے ڈوز آف ریڈ سیل, تو آپ کو پتہ ہونا چاہیے کہ آپ کا بلڈ بینک کتنا ہیماٹوکریٹ کا بنا رہا ہے. جو ایوریج ہمارے یہاں بنایا جاتا ہے, اگر وہ ایف ایف پی کا وہ والیوم نکالا جائے جو میں نے آپ کو بتایا, تو اٹس 0.6 to 0.7, ٹھیک ہے. اور اگر وہ اس سے کم ہے تو وہ آپ کو ریکوائرڈ ہوتا ہے 45 to 60% نیونیٹل ایکسچینج کو, تو اس لیے ہم ریکنسٹیٹیوٹ کرتے ہیں. وین یو ہیو اے ریڈ سیل آف ویری ہائی ہیماٹوکریٹ, تو اس کی فلو کا بھی پرابلم ہوتا ہے اور اس میں البیومن بھی نہیں ہوتے. تو ان دیٹ کیس یو ایکچولی ٹیک اینڈ یو ایکچولی ریکنسٹیٹیوٹ ود اے ABO compatible sort of plasma. واشنگ آف دا کمپوننٹس ریکوائرڈ ہوتے ہیں الرجک ریئیکشن کو ریڈیوس کرنے کے لیے. سو دیٹ واز واٹ آئی واز ٹاکنگ, دا اسٹرائل ٹیوب کنیکشن. یہ چیز چاہیے ہوتی ہے ایٹ ویری ہائی ٹیمپریچر, مور دین 600 ڈگری سینٹی گریڈ مومنٹریلی لے کے جاتا ہے اور وہ ٹیوبس کو سیل کر دیتا ہے آپس میں. اس کا فائدہ یہ ہوتا ہے کہ شیلف لائف بلڈ کی جو ہے وہ کم نہیں ہوتی. اگر آپ اوپن کریں گے سسٹم تو یو نیڈ ٹو ٹرانسفیوز دا بلڈ ود ان 2 to 4 hours, پریفریبلی 2 hours. اور اگر آپ اس کے تھرو کریں گے تو آپ اس کو اسٹور کر سکتے ہیں فار دا ریسٹ آف دا شیلف لائف. سو دیٹ از امپورٹنٹ. وی ہیو سین کہ اگر ایلومنائزیشن ریٹ جو ہے کرونیکلی ٹرانسفیوزڈ میں, دا ارلیئر دا ٹرانسفیوژن لیسر دا ایلومنائزیشن ریٹ. دا سیم ہیز بین پرووڈ. ہماری بھی ایک اسٹڈی کی تھی ہم نے پاتھویل کے ساتھ مل کے, دا سیم, اور میڈم جویریہ کا بھی شاید پرابلی ایکسپیرینس یہی ہوگا. سو واٹ از دیٹ مینز از دیٹ ایلومنائزیشن ریڈیوس کرنے کی بہت زیادہ ویلیو اور امپورٹنس ہے. اینڈ دا بیسٹ وے سو فار فاؤنڈ ورلڈ اوور از کہ لیوکو ڈپلیشن کرنے کا جو بیسٹ طریقہ ہے وہ لیوکو فلٹریشن ہے. دا بفی کوٹ پور جو ہے وہ جو ریڈیوس کرتا ہے, یعنی آپ دوبارہ سینٹریفیوگیشن کر دیتے ہیں, رفلی اس کے اوپر WBCs آ جاتے ہیں, ان کو پھینک دیتے ہیں اور باقی ریڈ سیل دے دیتے ہیں. اس کو ہم بفی کوٹ پور کہتے ہیں. دس از ناٹ لیوکو ڈپلیٹڈ. اس میں اتنا ہوتا ہے کہ جو WBCs ہیں وہ اس تھریش ہولڈ سے نیچے چلے جاتے ہیں کہ ان کو فیبرائل ریئیکشن نہیں ہوتا, بٹ وہ ایلومنائزیشن پریونٹ نہیں کرتا. ایلومنائزیشن اگر کسی نے پریونٹ کرنی ہے تو امریکن اسٹینڈرڈ یہ ہے کہ ایک RCC میں یا پلیٹلیٹ میں جو ہے وہ 5 ملین سے کم ہونے چاہیے WBCs, اور یورپین اسٹینڈرڈس کہتا ہے کہ جی 1 ملین سے کم ہونا چاہیے. دیٹ کین ناٹ ہیپن انلیس یو ڈو لیوکو فلٹریشن. سو بفی کوٹ از ناٹ لیوکو فلٹریشن, ٹھیک ہے. کچھ بلڈ بینکس آپ کو یہ کانسیپٹ دیں گے, بی شیور, کیونکہ یہ پچھلے دنوں جب میں آئی اسٹارٹیڈ سپورٹنگ دا رینل ٹرانسپلانٹ پیشنٹس, تو اس میں یہی تھا کہ جی وہ کہتے ہیں وہ جی وہ لیوکو وہ پور بنا کے دے رہے ہیں. میں نے کہا لیوکو پور از ناٹ لیوکو ڈپلیٹڈ. یور کڈنی ٹرانسپلانٹ پیشنٹ ول ہیو دس تھنگ ایلومنائزیشن. سو بی شیور دیٹ دے آر لیوکو ڈپلیٹنگ اینڈ سم بڈی از ڈاکیومنٹنگ کہ وہ لیوکو ڈپلیٹ کر کے کرائٹیریا میٹ کر رہے ہیں. بیڈ سائڈ جو فلٹرز ہوتا ہے اس کا پرابلم یہ ہے کہ آپ کو فلٹر کا فیلئر کبھی نہیں پتہ چلتا, اور جو پری فارمڈ سائٹوکائنز ہوتے ہیں وہ بھی جاتے ہیں اور فیبرائل ریئیکشن اس طرح پریونٹ نہیں کرتے. اوکے, واٹ از دا بینیفٹ آف دس لیوکو ڈپلیشن جو آپ لیوکو فلٹریشن سے کر رہے ہیں اس کرائٹیریا کو میٹ کر کے؟ دیر از اے ریڈیوسڈ فریکوینسی اینڈ سیویرٹی آف نان ہیمولیٹک فیبرائل ٹرانسفیوژن ریئیکشن وچ از دا کامنسٹ ریئیکشنز دیٹ یو انکاؤنٹر پرٹیکولرلی ان کرونیکلی ٹرانسفیوزڈ. اور دیر از اے ریڈیوسڈ رسک آف سائٹومیگیلک CMV انفیکشن. تو جو فلٹرڈ پروڈکٹس ہوتے ہیں دے آر CMV سیف, تو آپ کو CMV ٹیسٹڈ سیپریٹ انوینٹری نہیں رکھنی پڑتی. تو ایک تیر سے آپ 2 شکار کر لیتے ہیں, وچ از پرٹیکولرلی ریلیونٹ فار دا نیونیٹس اینڈ ٹرانسپلانٹ سیٹنگ. اور اسی طرح یہ اگر شروع سے پلانڈ ہے, کوئی افورڈ کر سکتا ہے اور اس نے بعد میں ٹرانسپلانٹ میں اس کو لے کے جانا ہے, تو دے مسٹ ریسیو لیوکو ڈپلیٹڈ پروڈکٹ, تاکہ ان کی ایلیمنائزیشن نہ ہو اور ریفریکٹرینس نہ ہو. دس ریڈیوسز mortality and organ dysfunction in events. These are proven benefits. These are probably and these are unproven clinical benefits. we'll not talk about this thing. Okay, transfusion-associated graft versus host disease. One of the manipulations that we do and modifications that we do is इसको prevent करना होता है. ये हमारे लिए भी setting में important है कि अगर first degree relative का blood दे रहा है, तो please make sure that you irradiate it. I've seen very bad, fatal GVHD in neonates and children because of this thing. तो उसमें ये है कि बिकॉज डोनर जो है वो तो रेसिपिएंट को फ़ौरन जो है वो समझता है और उसके अगेंस्ट माउंट कर लेता है रिस्पॉन्स, और रेसिपिएंट अगर रिलेटिवली इम्यूनो सप्रेस्ड है और वो इसके डोनर की HLA को रिकग्नाइज नहीं करता क्योंकि हाफ उसके साथ मैच होता है, तो दे वुड नॉट माउंट अ रिस्पॉन्स, और इसकी वजह से ये डोनर जो है इसके अगेंस्ट जो है वो ग्राफ्ट वर्सेस होस्ट डिजीज़ बना लेता है. अच्छा, सो दैट इज़ इरिडिएशन. सो एज सेड के वो लोग ब्लड टेस्टिंग करते हैं. So we have transfusion triggers. आपकी भी transfusion triggers बहुत सारी guidelines available हैं. It is important to calculate the dose of RCC, especially in chronically transfused, ताकि आपको पता हो कि आप कितना लेके जाएंगे, कितना वॉल्यूम दे के, और उसके बाद कितना इंटरवल के बाद उसको बुलाना है. Remember, rate of fall of hemoglobin is 1 gram per week. अगर कोई और प्रॉब्लम नहीं है, तो you cannot plan transfusion unless you have this information and you have calculated the dose. So that's the dose that you already know. And इसके लिए जो ट्रांसफ्यूजन जो आपको ब्लड एडमिनिस्ट्रेशन है उसके लिए इम्पॉर्टेंट है, ये करें. हमारे यहाँ प्रॉब्लम ये है कि जब बहुत हाई हेमाटोक्रेट का होता है तो एवरी क्लिनिशियन इज़ फाइटिंग विद द वॉल्यूम्स, वो फ्लो प्रॉपर्टीज़. ऐसे ही ट्रांसफ्यूजन नहीं हो रही, लगे में, तो उसके लिए बाहर वाले तो वाई सेट यूज़ करते हैं जिसमें एक साइड से सेलाइन देते हैं. हमारे पास वाई सेट्स नहीं होते, तो इट्स इंपॉर्टेंट कि ब्लड बैंक जो है वो न्यूनेटल पीडियाट्रिक के लिए एक सेपरेट बना के रखे कि उसकी हेमाटोक्रेट को एडजस्ट कर ले ताकि फ्लो प्रॉपर्टीज़ उसकी बेहतर हों. कोल्ड ब्लड ट्रांसफ्यूजन यूजली स्मॉल वॉल्यूम्स का कोई मसला नहीं होता, बट अगर लार्ज वॉल्यूम देना है तो मस्ट बी गिवन थ्रू दिस. एंड डू नॉट यूज़ रेडिएंट हीटर फॉर वार्मिंग द ब्लड, हेमोलिसिस कर देते हैं. So we should be aware of all the hazards of blood transfusions and do something जो कि starts off with the prescription, something in the blood bank, and finally at the monitoring at the bedside. So hemovigilance programs ने बताया है कि सबसे ज़्यादा incorrectly जो blood component transfusion होती है वो children में होती है, because right orders नहीं होते और right compliance नहीं होती blood bank से. So to conclude, blood transfusion therapy in neonates and pediatric patients is specialized and different from adults. Blood banks and blood transfusion services should have the knowledge and capacity to offer specialized services and products. Only education, training, communication and clinical services can translate into best practice and safety of patients. So we have expertise and our services can be utilized for this purpose. Thank you.
Thank you, ma'am, for enlightening us. Increased survival in patients with beta thalassemia major allowed for several complications for the disease and its treatment to manifest, one of which is bone disease. To discuss this important issue, we have with us Professor of Pediatrics, Professor Dr. Javeria Manan, who is the pioneer of thalassemia care in Pakistan and has dedicated her life to the cause. She has formulated many policies and guidelines for the care of thalassemia patients, in addition to working with Thalassemia International Federation. She is the recipient of Certificate of Excellence by the President of Pakistan, Dr. Rawalpindi, for her work in thalassemia. She is also the chairperson of Medical Advisory Board, Thalassemia Federation of Pakistan, and President, Thalassemia Society of Pakistan. I would like to call on stage Professor Dr. Javeria Manan to cast the light of her knowledge regarding bone diseases.
All the seniors present in this hall, the juniors, the students, Assalamu alaikum. I have to thank Brigadier Lodi for arranging this activity and giving me also a chance to learn many things. Right, thank you.
ये पॉइंटर है
जी
ये सिलेक्टर है अगर इधर नीचे कर दो ये सिलेक्टर
ठीक है ओके जब टॉपिक मिला मुझे मेटाबॉलिक बोन डिजीज़ का तो मुझे बहुत खुशी हुई, क्योंकि मुझे पता लगा कि ब्रिगेडियर साहब के बच्चे जवान हो गए क्योंकि ये प्रॉब्लम हमें मुझे और आदिल को बहुत साल पहले पड़ा था, जब हमारे थैलेसीमिया के बच्चे जवान हुए, और इनको भी पड़ गया तो मुझे बहुत खुशी हुई, बिकॉज दैट रियली टेल्स अस how much he is caring for the patients he treats. So metabolic bone disease is a very troublesome problem in thalassemia adult patients. Osteopenia and osteoporosis, which is called OOS, is the result of metabolic disease, characterized by low bone mass and microarchitectural deterioration, leading to increase in bone fragility and fractures. And this microarchitectural disturbances in the bone can often be seen as dysplastic changes in the bones in adult patients, and sometimes these patients are unnecessarily exposed to biopsies and suspicion of malignancy in the bones. So the radiologist has to be familiar with these changes in these chronically transfused patients. Normal bone density is more than -1. Between -1 to 2, -2.5 is osteopenia, and less than -2.5 is labeled as osteoporosis. The World Health Organization criteria for the diagnosis of OOS is osteoporosis in which the bone mineral density is more than 2.5 standard deviation below the young normal mean, that is T-score, which is actually 30 years of life, or the standard deviation in relation to patient's age and sex, and that is Z-score. Osteopenia is more than 1.5 to -2.5. This is again the same thing, giving you the different conditions. You can easily order a DEXA scan in which you can have the neck of the femur, the spine, which I'll show you in the next slide, as well as a graph on the side. And it's not difficult to pick up that the green is normal, the yellow is osteopenia, and then the osteoporosis. This is the spine which you will have the image. Again, just a representation of telling you the Z-score, which is according to the age and sex, and the T-score, which is a 30-year-old person comparison. You can sometimes have this type of graph also available from some centers, and very easy even for anybody to pick it up, that if the person lies below this, then he is osteoporotic. What are the causes of this metabolic disturbance in these children? There are many. The first, which has been mentioned by Brigadier Saab also, is the marrow expansion. Then the chronic anemia, which these patients suffer. The hemosidrosis, which is caused by the transfusion, and its chelation, that is also a reason for osteoporosis. You all know that sex hormones, they protect against osteoporosis. And in these patients, because of the iron overload, if the puberty is delayed, then you can have potentiation of osteoporosis. These patients, because of the high iron load, can have multiple focus करना ज़रा मुश्किल. Multiple endocrinopathies, in which these 4 are important, and this will also lead to osteoporosis. What are the clinical features? 20% of the patients will be asymptomatic, hence not be picked up. Then the symptoms which come with metabolic bone disease, the commonest is bone pains. Could be also just because of osteoporosis, but somebody having bone pains, you should always suspect, if it is really bad, that is there a microfracture underneath which can only be picked up by MRI and not a regular X-ray. These patients usually start to complain of low backache, and the OOS is found in 70 to, I have difficulty focusing it this pointer anyway. 70 to 80% of adult patients, they have metabolic bone disease. This is the whole list of investigations, but of course, not all of it will be available to all those doctors who will be taking care of thalassemia patient. So you can pick and choose whatever you want to do, but the minimum would be, of course, a calcium phosphate and vitamin D level. If possible, PTH would be helpful, and 24-hour urinary calcium. Endocrine profile in females and males can also be done along with thyroid function tests. But sometimes these hormones, when not available, you can just clinically look at the SMRs, and in female patients, you can order a pelvic ultrasound for the condition of the ovaries as well as the thickness of endometrium in the uterus. Liver function are usually available. Spinal X-rays are only helpful in severe cases, and MRI has to be done when they come with complications of osteoporosis like cord compression or extramedullary hematopoiesis. Also you need MRI. DEXA scans can be done now at many places for spine, hip, radius, and ulna. Preferably done annually, but not possible due to financial constraints, so should be done in non-transfusion dependent thalassemias at 10 years of age, and in transfusion dependent thalassemias at pubertal level, and after that, if you find it faulty, you have to repeat it every year because you would like to see if your therapy is helping. Since iron is the culprit, one of the culprits, so you should also look for the iron markers. There was a small study I did with 42 adult patients in which there were 19 males and 23 females, and the age range was 11 to 30 years. And just showing you the graph, this is actually growth graphs, but just to tell you that how much growth retardation is present in all our patients. This is again the growth charts. And here is the just a description that only the one person is here who has a good height and weight, and the rest of the patients, they had less, between 11 and 19 years. So this is just to tell you that there is tremendous growth retardation. and that which would also lead to now here is the Z-score for all the patients. Less than 0.5 are 9 patients, and in minus 2.1 there are 8 patients, and then there is a larger number of patients which is in minus 3 group. To show this graphically is easier to understand, that you see that majority of the patients, they lie below the blue line, and all these patients have osteoporosis. Only a single patient was at the osteopenia and osteoporosis level, and the rest of them all had metabolic bone disease. This is another way I've shown this. So how will you manage them? Most important in these patients is sex steroid replacement therapy, because these are adult patients. So you really have to see what is their SMR. And the first thing to replace would be the sex steroids. Then the calcimimetic drugs, anti-resorption drugs, which are used much later, and that is the bisphosphonates. And most of the time, you will have to use in your patients a combination of all 3 upper modalities. All patients with proven OOS and hypogonadism should have replacement therapy with sex hormones for at least 2 years regularly before you decide to jump to bisphosphonates. They should be provided with adequate dosages of vitamin D, which is 1,000 to 1,500 international units per day. Calcium supplementation 500 to 1 gram orally daily. Vitamin D, many patients who come to us as adults also have suffered liver damage. So simple vitamin D usually doesn't help, and we have to give them calcitriol to help their metabolic bone disease. Anti-resorption agents can be used, which are bisphosphonates. And in thalassemia patients, non-responders or poor responders to the therapy can be given. And in thalassemia intermedia, they can be given only if hypogonadism is present. The bisphosphonates, they reduce the risk of vertebral fractures by 40 to 50%, and non-vertebral fractures 20 to 40%. These are the various bisphosphonates and their dosages, and probably all of you know that there are this is the oral ones and the injectable ones. Combination therapy means that you are using bisphosphonates plus the HRT, especially in thalassemia major patients. So the other recommendations are that you have to improve their diet and give them an exercise plan regularly. You give them vitamin D and calcium supplementation, sex hormone replacement, which is HRT, anti-resorption agents if the above don't help, and if very severe, then you have to use the combination therapy. Thank you very much for your patient listening.
At Indus Hospital and Health Network, member Medical Advisory Board of Thalassemia Federation of Pakistan. Also the recipient of Certificate of Excellence by the President of Pakistan, Dr. Rawalpindi, for his work in thalassemia. I would like to call Dr. Adil Akhtar to take the podium.
Assalamu alaikum. Assalamu alaikum. अच्छा जाग गए हैं मेरे ख्याल से चाय के बाद शायद थोड़ा सा एनर्जी आ जाएगी. Thank you very much. I'd like to thank the organizers, especially Brigadier retired Munir Lodi Saab, Professor of Pediatrics here. This is a workshop. So मैं सिर्फ सवाल पूछूंगा, काम आप लोगों ने करना है, जवाब आप लोगों ने बताने हैं. तो ज़रा तैयार हो जाइएगा. First part of the workshop is always to understand कि आपकी audience कौन है. तो मुझे ये बताइए, undergraduate कोई है इधर? अच्छा, residents कितने हैं? हाथ खड़ा कर लें. ठीक है जी. Senior registrars? अच्छा ठीक है, thank you. And बाकी faculty. So I'm hoping to have interaction with you guys. ठीक है जी. And we'll see what we're going to do. So our learning objectives for this session, जी, वो जो पीछे एक लाइन है ना, वो बहुत दूर से मेरी नज़र इतनी अच्छी नहीं है. हाँ, आगे आ जाए. So our learning objectives for really this next 1 hour are, hopefully we'll be able to learn when to start iron chelation. How do we modify iron chelation depending upon the clinical scenarios? And really that talks about change in drugs, change in dosages, combination therapy, and stopping chelation, chelation in special situations, and hopefully we'll be talking about chelation in non-transfusion dependent thalassemics and transfusion dependent thalassemics. Now, there will be really two sources of everything I'm going to be discussing with you here today. The first source is the 2021 guidelines on the management of transfusion-dependent thalassemia. This is published by the Thalassemia International Federation. And two things I want to I would like to highlight here. Let me just pull up a... So one thing I want to highlight is this point. ये Thalassemia International Federation ने वैसे नहीं लिखा किताब के अंदर. It's very important to cure sometimes, treat often, but make sure comfort always. सबसे पहला जो काम हम ख़राब करते मरीज़ जैसे थैलेसीमिया तो हम सर पकड़ लेते कहते ओ हो बस जी अब ज़िंदगी अज़ाब पड़ जाएगी. That's not something you want to tell a patient. A patient comes to you for hope. Second thing, most important I want to talk about is really here. Throughout medical college and throughout a lot of our postgraduate education, we always talked कि ये बीमारी है, इसका इलाज ये है. एक कुक बुक रेसिपी होती है हमारे पास जिसमें अगर थैलेसीमिया इंटरमीडिएट है तो उसका ये ट्रीटमेंट है, थैलेसीमिया मेजर है तो उसकी ये ट्रीटमेंट है, ट्रांसफ्यूजन डिपेंडेंट है तो उसकी ये ट्रीटमेंट है. What a lot of us forget is we're not treating the disease, we're actually treating a patient. And so at times, depending upon the scenario, it's important that we tailor the treatment depending on the current situation, and as the child grows or as the situation changes, that same patient may need a different type of therapy. So, the good physician treats the disease. The great physician treats the patient who has the disease. So I hope all of us here really plan to be great physicians. The other source of my, all the information which I'm going to help try to walk you through is really the iron chelation guidelines which were published, the second edition, by Professor Javeria and our team. both are easily, freely downloadable. Everyone is smart enough to use Google and use online resources. So if you want the Thalassemia Federation of Pakistan's guidelines on iron chelation, they're downloadable from the website. I'll show you the page. And if you want the 2021 guidelines for the management of thalassemia from the Thalassemia International Federation, they're available on their website as well. This is where publications and treatment protocols, everything is available in a PDF format, free to download for you. And don't hesitate to refer to it wherever you have questions. So सबसे पहली बात ये है कि preventative types of iron chelation, एक preventative therapy होती है, एक rescue therapy, emergency therapy. So there's 3 types of iron chelation therapy. Can anyone think what preventive therapy is? Anyone? It's okay to be wrong. Ji, please. Excellent, excellent. So really, preventive therapy is therapy which is initiated before iron overload occurs in any organ. And rescue therapy? Anyone else? Before organ damage is preventive. Rescue therapy is when the iron overload has now reached a point where it may cause or already has caused organ damage. And that may be damage to the liver, that may be damage to the heart, that may be damage to the endocrine organs. So it's dependent upon that. And then what's emergency therapy? Can anyone give me an example of emergency where you may need emergency iron chelation therapy? Excellent, excellent. So whenever you have congestive cardiac failure or cardiomyopathy due to iron overload. Perfect, wonderful. Now, when we think about iron chelation, there's really 3 things you want to consider when you start iron chelation. One is which iron chelator are you going to choose? That's a very important decision. और अगर ये फैसला सही लिया गया तो the likelihood of success in iron chelation is better. Compliance to the drug or adherence to the therapy, extremely important. And dose adjustment. Now, why do we need dose adjustment? Dose adjustment का simple मतलब ये है कि अगर थैलेसीमिया का बच्चा है तो इस वक्त उसकी इतनी डोज देनी है, इस वक्त उसकी इतनी डोज देनी है. Anyone can think of why that's extremely important? उधर से कोई जवाब गलत नहीं होता. So one of the reasons why it's extremely important to make sure that you do dose adjustment is जैसे बच्चा बड़ा होगा वेट के हिसाब से उसने डोज भी बढ़नी होती है और अगर आप नहीं बढ़ाएंगे तो the likelihood is you will have suboptimal iron chelation. Second thing to realize is जैसे उसकी transfusion requirements बढ़ेंगी तो आपका iron overload भी बढ़ेगा. So your aim really is to maintain a negative iron balance. You want to get rid of excess iron, right? So if the child has recently suffered from an infection where he was required to get a greater number of transfusions than usual, so the likelihood is that the dose of iron chelation would need to be increased. And we'll talk more about that ahead. Now, everyone has probably seen this. Everybody knows that there's really 3 different iron chelator drugs. One is either given IV or subcutaneous, and the other 2 are given orally. And I'm not going to bore everyone on this. This is easily available on any of the websites we just talked about. But what I'm going to do is actually let's go through a case. And so the rest of this talk will be walking us through Abdullah's life as a thalassemic. So when Abdullah was 1 year old, he was diagnosed as transfusion-dependent thalassemic. He received a number of transfusions, and his treating physician diagnosed him as transfusion-dependent thalassemia. The questions which I have for the audience, and possibly those who have joined online, because I understand this is a hybrid conference, when would you recommend that they start Abdullah on iron chelation therapy? Which drug would you recommend them to start? And what dose would you recommend them to start at? So these are 3 questions. I want you to take 20 to 30 seconds to think about it, and then we'll go over the answers. And for those who have joined online, if they want, they can type it out in the chat box. So I'll give you 10 to 15 seconds to think about it, and then we'll look for answers. अब मैंने उस साइड से जवाब सुनने हैं, वरना मैं चल के आपके पास आ जाऊंगा. जी. So one answer was that you would like to wait till a serum ferritin of 1,000 or at least 1 year of regular transfusions. Okay. Anyone else? Anyone else have a different view? Does that mean we should do a serum ferritin level before we start the iron chelation? So there's some agreement on that? Okay. Any other thoughts? 10 to 20 transfusions, at least wait until there are 10 to 20 transfusions. Okay. Right, serum ferritin is more than 1,000. So let's look at what the guideline really says. So the child has to be over 2 years of age. That's the number one requirement. Even if under 2 years of age they have received 10 or 11 transfusions, you would not start iron chelation therapy until the child is over 2 years of age, and the reason for that is the risk of side effects significantly increases. And the safety profile of these medications is not proven under 2 years of age. And then what you said holds true. You mentioned 10 to 20 transfusions, it's mentioned here. It's also mentioned about a serum ferritin level of about 1,000, equal to or more than 1,000. But here the caveat is that do not wait for a serum ferritin level. If the other criteria are matched, go ahead and start your iron chelation. Do not wait for a serum ferritin level. Do not make the serum ferritin level a mandatory requirement for the initiation of iron chelation. ठीक है? Great. So Abdullah 2 साल पे आपके पास 1 साल के ऊपर आपके पास आया, फिर सवात या मर्दान चला गया और गायब हो गया, which is pretty typical for a lot of our patients. And then he comes to you at 3 years of age. He has been non-compliant. आपने उनको समझाया था कि 2 साल का जब होगा आपने ये दवाई इस्तेमाल करनी है. Oh sorry, कौन सी ड्रग इस्तेमाल करनी है? मैंने पहले जवाब दिखा दिया था. Sorry, which drug do you want to start? Sorry? So one option is Deficerox. Which preparation? So you know there's 2 preparations of Deficerox. So Deficerox is always oral. Does anyone know which 2 preparations are available? Sorry? Injectable Deficerox is not available. It is only meant to be an oral medication. What I think you're talking about is desferrioxamine, which is desferrol. So that is given IV or subcutaneous. Great, wonderful. So 2 preparations. One is a dispersible tablet of Deficerox, and the other is a film-coated tablet. The reason to know this is because the dosages of the two different preparations are different. Okay? So which one would you like to use? Okay, dispersible. How do you want to recommend that the child takes it dispersible? Okay, so one mention is 30 mg per kg per day. Any other thoughts? So how would you tell the mother to do it? So किस के बच्चे हैं इधर? छोटे बच्चे हैं, सुबह नाश्ता करते हैं? करते हैं? अच्छी माँ हैं आप. मगर the point is नहीं करते. I'm witness to that. Is sometimes एक लड़ाई होती है उनके साथ, and that's a fact of the matter which we sometimes forget. That actually keeping them empty stomach, making sure that they take the medication prior to half an hour before you're going to give them anything like that. And if they're school going, right, that becomes even more of a fight. You have a time period wait. So, and plus to keep in mind that when you recommend the dispersible tablet, you have to tell them कि चम्मच प्लास्टिक का हो और शीशे का ग्लास हो. कहीं वो लोहे का ग्लास ना इस्तेमाल करें और लोहे का चम्मच ना इस्तेमाल करें, या स्टेनलेस स्टील की जो बात होती है, राइट. एंड अगर आपने पूरे ग्लास में भर दिया तो मेकिंग श्योर दैट वो पूरा ग्लास पीते हैं. छोटे बच्चे को पूरा ग्लास पिलाना भी एक काम होता है. और फिर नीचे जो ज़रात रह जाते हैं उसमें भी थोड़ा सा दोबारा डाल के तो फिर दोबारा पिलाना. सो समटाइम्स इट कैन बी अ चैलेंज. एनी अदर चॉइसेस of medication? You can give the enteric coated. We'll talk about the dose in a minute. Any other choices? Deferriprone? Yes, okay. We'll talk about the dose. And what about desferol? Can you give desferol to a 2-year-old? Yes, no, maybe? Maybe? वो बड़ा safe सा answer है ना हाँ या ना. But yes, it can be given. It can be given. No issues there, right? You cannot use it under 2 years of age because you have to worry about cartilage damage in that as one of the possible side effects, and ototoxicity and nephrotoxicity. But keeping all of that in mind, you do have options. Now, how do you choose which option is right for your patient? Sorry. This is how you choose it. The first slide which I showed, treat the patient with the disease. मरीज से पूछो यार आप कौन सी दवाई अफोर्ड कर सकते हैं, आप कौन सी लेने के लिए तैयार हैं. Just because you have the best drug available and the patient cannot afford it, उसको वो दवाई प्रिस्क्राइब करने का कतन कोई फ़ायदा नहीं है जो उसने नहीं लेना. And that's why I started with this. That the most important thing to keep in mind is the patient. It's a joint decision. It's a partnership between the patient and the doctor whenever you treat a disease. It's not the doctor treating the disease, it's the patient who actually has to take the medicine. तो जीत के लिए दोनों की partnership अच्छे तरीके से होना बहुत ज़रूरी है. So make sure you're aware of the cost. Make sure you're aware of the possible compliance issues. Make sure you're aware of what choices are available. And at the time of the development of these guidelines, the film-coated tablet was not available in Pakistan, and thus you do not see the film-coated tablet mentioned here. But the point to keep in mind is you do have options, and the dosages are written there. ठीक है? So, अब 3 साल का हो गया, थोड़ा सा spleen बढ़ गया, he has been non-compliant, but transfusions भी कम हो रही है. His serum ferritin level shows a level of 2800. What's the first thing you're going to do now? 2800 इसका serum ferritin है. वर्कशॉप करने का यही मज़ा आता है कि आपको बोलना ज़्यादा नहीं पड़ता. You're looking for answers. You're hoping the audience speaks. So what about the 2800? Are you worried about the 2800? Why are you worried? Iron toxicity, possibly iron toxicity. Anything else? Are you worried about it? Are you sure this is a correct level? Yeah, ये false reading हो सकती है. Sorry, the units are incorrect. I apologize for that. But is there a possibility that the level is incorrect? Sorry? Right. So the first question you want to ask whenever you see this scenario is not jump on what to do, what treatment should I do, but first inquire whether this is a correct value or not. And the reasons, just like someone mentioned from the audience, could be the fact that this patient may have recently suffered from an infection, maybe Hep C positive or Hep B positive, right? May have some underlying infection going on, and that may be a falsely elevated serum ferritin. I'm not saying that it is the situation, but that's one question which you want to ask yourself whenever you're managing these patients. Very important. But let's suppose that this is a correct value. Then what would be your choice of iron chelation now? Combination therapy, right? And so you have your guidelines. And it says whenever you have the serum ferritin level above 2500, you want to use combination therapy. And the combination therapy really shows two options. Both of those options show D-ferrous Cyrox. One of them shows D-ferrous Cyrox, the other shows D-ferriprone, but both of them show desferrioxamine. And notice that the oral iron chelator is given on a daily basis, whereas the subcutaneous or infusion may be given 3 to 4 or 4 to 5 days in a week. What this does not mean is 3 to 4 days of desferol and 2 to 3 days of the oral iron chelator. That is incorrect. Good. So now Abdullah comes back. This time क्योंकि आपने बहुत डांटा, ठीक है जी, उनको कहा कि जी आप कर क्या रहे हैं, तो 6 months के बाद ये आपके पास follow-up पे आ गया. वो कहते हैं डॉक्टर साहब इतनी मेहनत हमने की है, पिछले 6 महीने से हम इंजेक्शन भी लगा रहे हैं उसको, हम उसको दवाई भी बाकायदगी से दे रहे हैं जो आपने रेकमेंड की है, तो अब उसका तो बढ़ गया है, 2800 था पहले, अब 3000 हो गया. What are you going to do? Okay. Why are you concerned about the diet? ठीक है, ठीक है, ठीक है. Say. Anyone else? Number of transfusions in the past month, that's important. Okay. Anyone else? Sorry? अगर किसी ने उसको आयरन सप्लीमेंट दिए ना, तो उसको तो आप बस कुछ ना पूछें, right? But you're right, it's an important question to ask. G? Recurrent infections, okay. So I'm going to take this one by one. Sorry? Compliance of the medication, very important, an extremely important question. Right, so the way they're actually giving the medication, excellent questions. So one thing I want to point out as a discussion point, keep in mind if the child is a transfusion-dependent thalassemic, the amount of iron this child is getting from his diet is actually minuscule. Itna kam hoga compared to the amount of iron he is receiving from blood transfusions. And thus, we do not do any dietary restrictions to transfusion-dependent thalassemics. I'm going to repeat that. We do not do any dietary restrictions to patients with transfusion-dependent thalassemics. Where the flip side is, if they are non-transfusion-dependent thalassemics, we do dietary restrictions because their iron amount which they're getting from the diet is 5 times more than normal, versus when we look at the amount of iron they may be getting by infrequent blood transfusions, वो बहुत थोड़ा होगा. So in simple terms, अगर transfusion dependent thalassemia है तो आपने जो खाना पीना है उसने खाए पिए, और अगर transfusion thalassemia non-transfusion dependent thalassemia है तो उसमें आपने dietary restrictions ये चाय ज़रूर recommend करनी है हर खाने के बाद, ताकि iron absorption उसके gut से कम हो. So that's the just answer, hopefully addressing the first point. Second, very good questions. You want to talk about the compliance. You want to make sure that the way they're giving the drug is appropriate. You want to talk about whether they're suffering from any infection. मैं कहता हूँ सब कुछ सही है, ये 3000 आया, अब क्या करना है? माँ बाप कह रहे डॉक्टर साहब हमने तो 100% जो आपने कहा है जैसे कहा है वैसे किया है, तो ये बढ़ क्यों गया? इसका मतलब दवाई काम नहीं कर रही. जी? So one thing I want to talk about just on the serum ferritin is what you need to realize is that serum ferritin is not very exact. There are advantages. This is an indirect measure of the iron overload. So what you need to understand is that there are certain advantages why we use serum ferritin and why we don't do a liver iron concentration every time, or a T2 star MRI every time of the heart. And the reason is because it's easily to repeat. A blood sample आपने देना है. It's relatively cost effective. We look at the trend versus an individual value. So 2800 और 3000 में शायद इतना ज़्यादा फ़र्क नहीं है, right? We do know for a fact that if we maintain serum ferritin levels less than 1000, the outcome is expected to be much better, and there's significant evidence to support that. And we do understand that it helps us wherever we need to adjust the dose. So, जो हम dose 4000 पे use करेंगे वो शायद 500 पे नहीं करेंगे, and that's what we use the serum ferritin. But the flip side is that obviously it's an indirect estimate. It is affected by inflammation. It does not indicate the exact iron load, and the relationship varies depending upon the chelator and in different diseases. So that's why in the guidelines what we have clearly recommended is, and I hope you can see this, that if it is a rise of less than 500, 2800 से 3000 तक का rise जो है 200 का हो गया, so it's within 500. So continue the same dose and repeat serum ferritin at 6 months. Now I want to make a little disclaimer here. The Thalassemia International Federation recommends it at 3 months. Every 3 months you should do a serum ferritin. We currently at the moment do not recommend that because we feel that that is too early in Pakistan to keep on getting serum ferritin levels. So that's why at the moment the Thalassemia Federation of Pakistan is recommending it at 6 months. Although you should know what the international guidelines say. And again, combination therapy continues. Now, Abdullah is 4 years old. His mother is now complaining कि डॉक्टर साहब वो जहाँ पे वो लगाता है ना डेस्फरॉल तो दर्द होती है, and there's a nodule which is created. What would you advise? So good. So one is rotate the site of administration. What else? Anyone from in the back? Please, again, no answer is a wrong answer. Sorry? Shift to IV, okay.
So if you
Slow infusion. Okay. Anyone else? So there's a couple of things you need to make sure. Number one is that the dilution of desferol is actually 10%. So hota ye kam volume hoga, jaldi chala jayega. And you'll see this more in older children, where let's suppose if you have a 500 milligram desferol injection, kitne sterile water mein aapne dalna hai? Kitna 10% solution ke liye? You want to put it in 5 ml. 2 injection kitne mein dalenge? 10 ml. 3 injection kitne mein dalenge? Kitne? 15 ml, right? 4 injection kitne mein dalenge? 20 ml. जो आपका बटरफ्लाई इन्फ्यूजन पंप है, तो किसी ने देखा है बटरफ्लाई इन्फ्यूजन पंप? किसी ने नहीं देखा? So this is subcutaneous. आपने देखा है? Good. So this is subcutaneous butterfly infusion pump जो आमतौर पर बच्चे is portable, batteries पे चलता है, वो आमतौर पर जेब में डाल देते हैं, या हमारी जो बच्चियां हैं, they make a nice purse and they wear it, और वो सबक्यूटेनियस इंजेक्शन भी चल रहा होता है और वो कॉलेज स्कूल वगैरह जा रहे होते हैं. That can usually accommodate a 10 cc syringe. So what they commonly do is 3 इंजेक्शन वो 10 cc में डाल लेते हैं ताकि वो फिट आ जाए. Not recommended. That's one of the possible reasons why you can get nodules. Second thing to keep in mind is one point which you all mentioned is कि तेजी से चला दिया. So how long should the subcutaneous infusion run for? A minimum of 8 hours, 8 to 12 hours. The reason is the longer the iron in the plasma is exposed to the desferol injection or the desferol molecule, the longer the chelation will continue. The minute the infusion is stopped, because the half-life of desferol is hardly 15 minutes, so जैसे वो infusion रुकी, iron chelation will stop. Very important point to keep in mind. Proper site, we talked about the rotation of sites. The angle of the needle, अगर आप needle बहुत superficially लगाएंगे, तो वो epidermis में लगा होगा. That will cause pain, that will cause nodules. And if it's too deep, again it will cause problems. So you want it to be actual in the subcutaneous. And the best way to do it is pinch it at a 45-degree angle. और उसके बाद अगर आप थोड़ा सा पीछे वो जो उसकी ट्यूबिंग है उसको हिलाएंगे तो वो अटकेगा नहीं कहीं पे. तो अगर वो easily movable है without any discomfort or without any pain, then you're in the right place. ठीक है जी. Now Abdullah is 12 years old. He presents to the emergency with congestive cardiac failure and arrhythmias. आपकी emergency duty लगी हुई है. आपने क्या किया? फटाफट अक्लमंदी के साथ instead of bolus Lasix injections, you gave a continuous IV infusion of Lasix. Because he also has arrhythmias, you started amiodarone. You plan for a blood transfusion ताकि उसका hemoglobin ऊपर आ जाए. How will you initiate emergency iron chelation in this situation? So can you give me a little more detail? You're on the right track, but a little more detail, please. Okay. Okay, great. Anyone else? जी इधर से कोई आवाज मुझे आ रही थी. So you want to start IV desferol right away. One thing to keep in mind is IV desferol is recommended, but also keep in mind that it can cause fibrosis in the veins. So that's why if you have an option of, in the first case when we're talking about, you want to prefer subcutaneous infusions rather than IV. But in this situation where it's an emergency, you want to give IV. and you want to start as soon as possible with your Desferol IV. Use it in a 100 ml solution. So you don't want to give too much fluid either. अगर आप 1 लीटर में डाल के लगाएंगे तो the child will suffer from fluid overload, right? And as soon as the child can take orally, like you did mention, you want to start deferriprone because it is relatively more cardioprotective. Great. So we talked about it, continuous infusion because it reduces the exposure to toxic free iron. We talked about desferrioxamine at a higher dose and recommended as a 24-hour infusion. We talked about deferriprone 75 milligrams per kilogram. As soon as oral, apologies for this mistake, it's not oral iron, but as soon as oral is tolerated by the child. Not iron, but oral medications or oral food is tolerated. And keep in mind, only add vitamin C when the heart dysfunction has settled. Normally, it will take 4 to 6 weeks before you can stop the IV chelation, and the subcutaneous 24-hour continuous IV infusion of your chelator, usually after 3 months. Special situations for iron chelation therapy, obviously the rescue to remove the myocardial iron. Prior to pregnancy, there is a situation where you may want to do intensive iron chelation, and obviously prior to bone marrow transplantation. Great. Now Abdullah's 12 years and 3 months old. वो बेहतर हो गया था congestive cardiac failure से, and you recommended that he gets a T2 star MRI of the heart. He got a T2 star MRI of the heart and the result shows 4.8 milliseconds. That should be milliseconds. What do you do now? How do you chelate him? Just like you mentioned very rightly that you want to choose a drug which will be more specific to removing iron from the heart, and which is deferriprone in this situation. So deferriprone being cardioprotective, there's been studies which show whenever you have left ventricular ejection fraction drop in it, if you give deferriprone, it does significantly improve it. And 3 years use of deferriprone monotherapy is associated with significant increase in left ventricular ejection fraction in patients. Now Abdullah is 14 years old, but now he's a typical teenager. He says, "Maine injection nahi lagana, jo marzi ho." His serum ferritin level is 4,300. We know he needs combination therapy, but he refuses to take Desferol. What do you do now? Danda pakadne hai usko. So deferricyrox plus deferriprone. So this is one of the rare situations where you may want to use that for a small period of time until you can switch to monotherapy. Okay. He's now 16 years old. He's been taking his oral medication, but recently suffering from right-sided knee and ankle pain. What do you need to do? So Professor Javedia just earlier mentioned about metabolic bone disease, but any other possibility? Which side effects? Sorry? थोड़ा सा ऊंचा बोलें. Okay, damage to bone cartilage. Anything else? Side effects of what? Iron chelator. Which iron chelator causes this specific side effect? Deferriprone. Deferriprone can cause joint pains, and they can be debilitating enough that you have to stop the drug. Otherwise, the patients will become bedridden. Now Abdullah is 18 years old. Abdullah ki sari zindagi ki kahani chal rahi hai na. He now complains of abdominal discomfort and intermittent constipation. alternating with diarrhea for the last 6 months. Because of these complaints, he's become non-compliant with his oral iron chelator. What do you do now? Sorry? Side effect of any of the oral iron chelators for that matter, whether it's dispersible D-ferricidox or whether it's oral D-ferriprone. Both of them can cause this. What do you do now? What choice do you have? Sorry? You can give IV or subcutaneous. Any other possibility? So you can use the film-coated tablets, right? They have a significant improvement in the discomfort. And I'm just showing this here. This is from an Eclipse phase 2 trial where they do the dose of the film-coated tablet. FCT stands for film-coated tablet. 14 milligrams compares to the dispersible 20 milligrams. So you have a lesser exposure to the amount of drug, and yet you get the same amount of chelation. And you can see at the bottom here the symptoms actually are not as severe or not as frequent when you compare it to the dispersible tablets. Yes? Sorry, क्या पिया करें? Actually, sometimes that can work opposite. अगर आप milk intake बढ़ाए ना, it can cause more gaseous distension and abdominal discomfort. So probably not the best option you have. So now Abdullah's 22 years old. We're almost getting to the end, so just a little more patience. Thank you very much. But Abdullah's now 22 years old. He's been having high-grade fever, cough for the last 2 days. He's had an increased requirement of his packed RBC transfusions over the last 2 months. His CBC shows a hemoglobin of 8, a WBC count of 4,000 with neutrophils 20%. What should you do? Sorry? Febrile neutropenia. Great. Which drug can cause febrile neutropenia? D-ferriprone, right? So what do you need to do? You need to stop the drug and see if the counts come up. Most of the time, if it's drug-related, the counts should come back up, right? So whenever you use D-ferriprone, it's important to monitor whether they suffer from neutropenia or agranulocytosis. You want to rule out other possible causes of agranulocytosis or neutropenia. You want to make sure you do a CBC every 10 days. And if they do suffer one episode, you may re-challenge them once because there may be a coinciding infection at the time that this presented. But if still that does not happen, then you don't want to re-challenge them again, and that's probably not a drug you want to use. The last 2 or 3 slides are very important, and we're going to be just talking about maintaining a maintaining a negative iron balance. इतनी आदत होगी ना इसकी, मैं भूल ही गया कि मैंने पहना हुआ है. But maintaining a negative iron balance. Whenever you have an increased rate of blood transfusions, अगर blood transfusions ज़्यादा लग रही हैं, so you need to actually increase the dose to make sure that you're getting appropriate negative iron balance. And if I'm just going to explain this table, this over here shows the transfusion rates. This is a low transfusion rate, intermediate and high transfusion rate. This is the dose of desferrioxamine used. And this is the percentage of individuals who actually maintained a negative iron balance. So the higher the transfusions and the lower the dose, the less number of individuals are actually maintaining a negative iron balance. Let's see that with another drug. When you look at the dosing with D-ferricidox, whether that's the dispersible tablet or the film-coated tablet, the asterisk and in brackets is the dose of the film-coated tablet, and the dose of the dispersible tablet is on the other side. So 10, 20, 30, if it's a higher transfusion rate, you'll get a lesser number of people actually going into a negative iron balance. And if you have a low transfusion rate, more individuals at different levels of the drug will maintain a negative iron balance. We're almost done. Abdullah's 24 years old. He's been compliant with his medication. His serum ferritin is 280. Can we stop his iron chelation? No? You want to maintain it? At what dose? So you can use it at a very low dose, or you can actually intermittently stop it. You have both options. One last case I'm just going to discuss because this is a little different. There's only one little small point you need to remember in this. Samina, 11-year-old, is a non-transfusion dependent thalassemic who is well maintained on hydroxyurea, has never required any blood transfusions. Does she need iron chelation? How many say yes? Just raise your hand. How many say no? Raise your hand. How many don't know? Raise your hand. Okay, so the important point here is yes, she does require blood transfusions, because keep in mind that if any child is over 10 years of age, despite the fact that they may have never received blood transfusions, but if they maintain a lower hemoglobin, they are going to have erythropoietin secreted and they're going to have an increased absorption from the gut, which you want to maintain a serum ferritin level of less than 300. And that's the last key point I have. To summarize, a lot of summaries, but we know that chelation therapy is an effective treatment modality. Chelation. Cardiac iron gets accumulated later in the liver and is rare before 8 years of age in a subset. And the rest we already talked about, but at the end I just want to make sure that we achieved the learning objectives which we initiated, and you guys have to help me here. Were we able to understand when to start iron chelation, yes or no? Yes. Shukr. Were we able to understand modification? How do you modify in iron chelation in different clinical scenarios regarding changing drugs? Yes. Halka sa yes aaya. Changing in the doses? Ye to aur halka ho gaya. Combination therapy? Ah, shukr. Stopping chelation or interrupting chelation? Chelation in special situations? And chelation in non-transfusion dependent and transfusion dependent thalassemics. Okay, thank you very much. If there's any questions, I'd be more than happy to take questions. Ji.
पेशेंट्स आते हैं हमारे पास तो
Hydroxyurea.
हाइड्रोक्सीयूरिया इस्तेमाल करते हैं तो 2 साल तक वो नहीं आते 2 साल के बाद जो है तकरीबन 2 साल के बाद फिर वो आना चाहिए 2 साल का गैप रख के आपने बताया कि उनको ट्रांसफ्यूजन्स मिलनी चाहिए फेरिटिन लेवल कम करने के लिए तो ऐसा क्यों होता है कि वो गायब हो जाता है पेशेंट
So अगर मैं आपका सवाल प्रॉपर तरीके से समझाऊं, एंड प्लीज़ करेक्ट मी अगर मैं नहीं समझा, कि आप बता रहे हैं कि आपके कुछ ऐसे पेशेंट्स हैं जो हाइड्रोक्सीयूरिया पे वेल मेंटेन्ड हैं, राइट? 2 साल से कम उम्र के, उनको 2 साल से ज़्यादा, और उनको रेगुलर ब्लड ट्रांसफ्यूजन्स नहीं लग रहे, राइट? और आप आईवी को डेस्फेरॉल की बात कर रहे हैं? So आपका मतलब है कि लेट्स सपोज अगर 2 महीने का बच्चा है या 3 महीने का बच्चा है जो पहली बार 2 साल से बड़ा बच्चा, मैं शायद सवाल नहीं समझ पाया.
नहीं, आपको एक रात इसलिए कि वो 2 साल आए कि उसको भी पकड़ लो, माँ बाप को भी पकड़ लो, लेकिन अगर कोई मैनेजमेंट का इशू है तो वो मुझे बताओ कि तुम्हारे जहन में क्या है?
सर मैनेजमेंट में सर ने भी बताया कि जो है वो अगर वो ट्रांसफ्यूजन को लेनी पड़ती है कि वो अगर आयरन का बढ़ जाएगा पेशेंट को चाहिए नहीं कि वो हमारे पास
तो आप तो कह रहे हैं कि वो वेल मेंटेन्ड है, इसमें तो सिर्फ काउंसलिंग का प्रॉब्लम है ना कि जो पेशेंट
दूसरा ये है वेरी इंपॉर्टेंट पॉइंट जो मैडम ने बात की है, याद रखें हाइड्रोक्सीयूरिया के साथ आपने LFTs भी मॉनिटर करने हैं, आपने दूसरे साइड इफ़ेक्ट्स भी मॉनिटर करने हैं और हर 3 महीने के लिए मॉनिटर करने हैं। अगर आप 2 साल के लिए छोड़ें तो आप काफ़ी सिग्निफिकेंट रिस्क में डाल रहे हैं। दूसरा ये है कि आप जो लोअर लेवल्स ऑफ हीमोग्लोबिन में मेंटेन करने के लिए भी ना एक स्पेसिफिक क्राइटेरिया है। जस्ट बिकॉज वो नॉन ट्रांसफ्यूजन डिपेंडेंट थैलेसीमिक है या थैलेसीमिया इंटरमीडिया है, कुछ ऐसे सिनेरियोज हैं जिनमें उनको रेगुलर ब्लड ट्रांसफ्यूजन स्कीम्स पे डालने की ज़रूरत है और टाइमली है। जैसे अगर फेशियल एब्नॉर्मैलिटीज़ आ जाते हैं, फोरहेड की बॉसिंग आ जाती है, मैंडिबुलर प्रोमिनेंस आ जाती है, ये इन चीज़ों को आपने प्रिवेंट करना है, तो इसलिए उसको रेगुलर फॉलोअप बहुत ज़रूरी है। बट थैंक यू फॉर दैट क्वेश्चन। एनी जी मैम, the film coated tablet, I'm not exactly sure. Shoaib, can you share the price of the film coated tablet?
360 की टैबलेट है, उसकी जो प्राइस है दैट इज 7500 रुपीस पेशेंट प्राइस कॉन्वर्टिंग।
दोबारा ज़रा क्लियरली बताइए।
ये 3 स्ट्रेंथ में अवेलेबल है, 90, 180 एंड 360। मोस्टली 360 यूज होती है क्योंकि हाई डोज चाहिए होती है, उसमें इसकी जो 360 की पेशेंट प्राइस है फ्रॉम आवर 22 दैट इज 7500 फॉर ऑल दैट। 30 टैबलेट्स का पैक है।
सिंपल कैलकुलेट कर ले, कोई बात नहीं करें। सो 30 टैबलेट्स ऑफ 360 तकरीबन 7500 का है। 250 rupees per tablet. Any other questions? If there's any questions online, I can answer those. Sure. जी।
जैसे सर पिछले दिन हमारे पास एक पेशेंट थी, शी हैड सेलुलाइटिस और सेप्टिक आर्थराइटिस सस्पेक्ट कर रहे थे और सिवियर बोन डिजीज। उसमें सर आई वाज हर्ड इन एन ऑनलाइन सेशन कि जब बोन डिजीज होती है तो उस दौरान जो चिलेशन हमसे डेस्फेरोक्सामीन से जो कर रहे होते हैं वो हमें होल्ड कर लेनी चाहिए।
जी एब्सोल्युटली
इन्फेक्शन भी
बिल्कुल
और ज़्यादा डिबिलिटेटिंग हो सकता है।
राइट।
तो उसमें सर हम फिर चिलेशन का क्या करें, क्योंकि उस पर्टिकुलर पेशेंट में ओरल को कोई भी लेती थी तो उससे इंटॉलरेंस थी उसकी और दूसरी तो हम दे ही नहीं सकते थे।
So it's not necessarily So it's not necessarily bone disease which is the problem, it's the cellulitis or the infection. So the key point is you do not want to give IV desferol because what it does, it provides more available iron और कई ऐसे बैक्टीरिया मौजूद हैं which love iron and they thrive in iron rich environment, तो वो फिर सेप्टिसीमिया में चले जाएंगे, DIC में चले जाएंगे, तो वो आपने नहीं देना during that acute phase. What you would like to do is treat that acute phase of the infection, and then after that you can go ahead and use the iron chelators. Now, I understand that there's sometimes still is a problem with the tolerability of it, but usually as they continue to use it, वो tolerability ज़्यादा palatable हो जाती है. So I hope that answers your question. Madam Pellet would like to add into that.
I would just like to add a little bit on it. He's absolutely correct that you have to stop this, right? But your patient will, after the treatment of infection, be with you with osteoporosis, right? So it depends how old is your patient, what is the SMR of that patient, and you can only reduce the dose of chelating agent to a level for the time being at which he maintains his serum ferritin. Reduce it, like if he's taking from 40 deferricerox, bring him down to 20, but don't stop it. And then add calcium, vitamin D, if you need sex steroid, and monitor your patient repeatedly, right? If the serum ferritin starts to rise at 6 months interval tremendously, then you can increase the dose to 30 milligram per kg per day. Would be, generally we do a DEXA scan after 1 year, But in this particular patient, then we will do it after 6 months and see if there is a deterioration or not. So with 30 milligram, then you continue another 6 months and then see again. And if your DEXA scan goes on decreasing repeatedly because it's a person who is like 30 years old, then you have to resort to bisphosphonate, NHRT. Okay?
Thank you very much, ma'am. Yes, just let me check. Is there any questions online at the moment? No. Okay, please.
Once it was like, you were not able to download it freely. It was to how you become a member of that.
नहीं मैंने इसलिए स्क्रीनशॉट दिखाई थी आपको स्क्रॉल डाउन करना पड़ता है काफ़ी ज़्यादा और फिर आपको पब्लिकेशंस की जगह आ जाती है ये सो अगर आप TFP की वेबसाइट अच्छा अब मैं उधर आके ना आपके साथ मैं कर लेता हूँ कोई इशू नहीं I'll make sure that's available or you can always email me and I can always email you it just for the ease.
Okay, thank you.
No problems. Yes, there's a question right here. I think I'll take 2 more questions after this if this then and then there's comments from Professor Javedi and Dr. Naveed. If you have any comments, please do add. Assalamu alaikum. So 2 things to keep in mind. That's a very good question. First of all, what we need to realize that is we want to avoid splenectomy as much as possible. Because what the spleen also does is sort of protects a lot of the iron which is being excessively transfused into the patient. वो एक iron store भी बन जाता है ना जो वैसे iron आपके बाकी organs के लिए available नहीं है. तो स्प्लीन बहुत ज़्यादा आयरन की वजह से डैमेज नहीं होता तो वो एक वैसे वो मगर जैसे आप स्प्लीन निकाल देंगे ना तो अगली बार वो आयरन और कहीं नहीं जाएगा वो साथ सीधे डायरेक्ट ऑर्गन्स में जाएगा सो आई नो सम पीपल हु डू रेकमेंड दैट इंटेंसिव आयरन किलेशन कर लो पहले बट दैट्स नॉट रियली द राइट वे टू डू इट बिकॉज यू आर नॉट प्रिवेंटिंग व्हाट इज़ इनएविटेबल सो कॉन्सेप्ट ये है कि पहले तो हम जितना ज़्यादा स्प्लीन को हम बचा के रख सकते हैं वो हम करें और अगर हम नहीं बचा सकते तो हम इंश्योर करें कि पेशेंट स्प्लीनेक्टमी के बाद भी रेगुलर आयरन किलेशन पे ज़्यादा बेहतर तरीके से मेंटेन हो क्योंकि अब वो जो एक ऑर्गन मौजूद था पहले वो जहाँ पे आयरन एक स्टोर हो जाता था और आयरन हमारे लिए ख़तरा नहीं था वो अब निकल गया है ठीक है जी Any other questions? Ma'am, if you have any comments, please. Wonderful. Dr. Naveed, Professor Tahir. Thank you very much. I hope you all enjoyed this session. I hope koi soya to nahi tha? Nahi, chal. Thank you. Thank you very much.
Thank you, sir, for such a meaningful session. There are many misconceptions regarding the diagnosis of thalassemia intermedia. There still are many gray areas in the diagnosis and management of thalassemia intermedia. They are managed with regular transfusions and become transfusion dependent. The session is now handed over to Professor Dr. Javeria Manan for interactive session on thalassemia intermedia. Ma'am.
अच्छा
ऊपर थोड़ा करके निकालना ऊपर हाँ इधर लगाए ऑन कर ले इधर रखने रखना
Okay. Let me first tell you what is a non-transfusion dependent thalassemia. Non-transfusion dependent thalassemia was declared a entity, separate entity in 2013 by Thalassemia International Federation. And these are the patients who do not require regular blood transfusion for survival, like thalassemia major, but they may require infrequent transfusions. It includes 3 entities: beta thalassemia intermedia, mild or moderate hemoglobin E and B disease, and the third is alpha thalassemia, which is hemoglobin H disease, because as pediatrician you know that the 1 and 2 they do not survive. This is a deletional thalassemia. Alpha thalassemia is a deletional thalassemia. Thalassemia major is a mutational thalassemia, right? There are mutations, like in the morning you heard there are more than 400 different mutations which are responsible for beta thalassemia. But alpha thalassemia is a deletional, 4 genes, 1 gene deletion, 2, 3, 4, okay. So if you look at the epidemiology of NTDT, and I was very happy that Brigadier Saab also showed a figure of 63,000 total hemoglobin cases, and then 23,000 were those who were the non-transfusion dependent. So that holds true, because if you look at it, then it tells you how important it is for you to find out whether your patient is NTDT or not. Because if there are 68,000 total children who have a thalassemia syndrome, and 23 means 1/3, about 1/3 patients are those who do not require a regular blood transfusion, that why don't we make life simpler for the blood banks? Why don't we make life simpler for the blood donors? I think we need to look into it very, very carefully. The carrier rate for beta thalassemia is globally 1.5%, pretty high. But if you take it country-wise, like our country, it ranges from 5 to 8%, right? That is the estimated. That is not the estimated, that is actually a researched, because these researches have been done by General Soeb and many other, and me and myself and Adil have also done a research in this. And this is so high in the, because of the consanguinity which is prevalent in our country. Alpha thalassemia is 5%, but the sickle gene statistics we don't have worldwide, right? But we do have sickle gene in Balochistan and some areas of KPK, the border areas, which are adjacent to Afghanistan, because it is much more common in Afghanistan, and there is kind of an overlap, people are coming here and there. This is, I'll just leave. Okay, I'll just explain to you why thalassemia major and non-transfusion dependent thalassemias are different diseases. Because the phenotype of beta thalassemia syndromes is dependent upon 3 types of modifiers: primary modifiers, secondary modifiers, and tertiary modifiers. The primary modifiers are the mutations which cause the disease. Like earlier in the morning it was said, it is IVS 1-5, frame shift 8-9, and frame shift 41-42. So some of the mutations like IVS 1-5, IVS 1-1, these are severe mutations. So if a child who inherits only a single disease, a single gene, and that gene is a severe disease, he can present as a phenotypically mild case of thalassemia intermedia, right? Or if there is a patient who has a moderate gene severity wise along with he is homozygous, one moderate gene, the other gene is silent like CAP+1, then he will be a homozygous thalassemia intermedia. So let's just learn right here that thalassemia intermedia can be heterozygous as well as homozygous. And why is it important for us to know? Because it has an implication in the chorionic villus sampling report. Because if a CVS report comes to you and it says the fetus is heterozygous for the mutation, as a pediatrician, you must know the proband. If your proband is thalassemia intermedia, then you will look at the mutations and see what are the mutations in the mother and father and what is the mutation in the proband. If the proband has a single gene of a severe mutation, then all fetuses which have a single mutation will be intermedia. And this is a point which is responsible for defaming the chorionic villus sampling. कि लोग कहते हैं जी हमने जी टेस्ट भी कराया था 12 हफ्ते में हमल का और हमें कह दिया गया कि आपका बच्चा बिल्कुल ठीक है, और उसके बाद वो बच्चा जो है उसको अब 8 साल की उम्र में खून लग गया और अब वो के डॉक्टर कह रहे हैं कि इसकी तिल्ली भी बढ़ गई है और इसको तो अब खून बार बार लगेगा। ठीक है, तो ये इसकी म्यूटेशंस को समझना और उनके बारे में इंफॉर्मेशन होना इसलिए ज़रूरी है। देन देयर आर सेकेंडरी मॉडिफायर्स, मीनिंग देयर बाय के जीनोटाइप कुछ भी हो, if there are secondary modifiers, then they can change the phenotype, the severity of the disease, the need for blood transfusion in that patient or any other management modality in that patient. And this is the secondary modifier. The most important thing is alpha thalassemia. If a patient has a mutation for beta thalassemia and a deletion of alpha thalassemia, then the imbalance between the alpha and beta is going to be less. And if there is a less mismatch and the alpha chain does not combine together to damage the RBC cell membrane and cause hemolysis, then the disease is going to be milder. There is another scenario in which there is increased expression of alpha hemoglobin. So if the expression is more, again, the hemolysis is going to be less. In some patients, they can have in intermedia, when they grow up, they have reduced demand on blood transfusion, and that is because in adult life, there is an effective synthesis of gamma chain. Then delta beta is another, and in the last line, this is what we were talking earlier on, that the polymorphisms like BCL, 2A, KLF1, HBS1L, and MIB. If these polymorphism, if these SNPs are available, these are called SNPs, single nucleotide proteins. If they are present, they again reduce the severity of disease. Then there are tertiary modifiers, and in tertiary modifiers, a very, very well-known polymorphism which now people have started to do XMN1 polymorphism regularly, that also has a ameliorating effect on the expression of the disease. But in our study in Punjab Thalassemia Prevention Program, we have seen that XMN1 polymorphism is not that common. Instead, HBS1, HB-SIL कहते हैं इसको हम, HB-SIL and MIB, they are more common. And then there are a few others which are more common in our community. So these three are actually the things which decide whether a patient is going to be thalassemia major or thalassemia intermedia. So what happened, I'll come to that later. Let's first look at this slide. And this was an old table which is given in the publication of Thalassemia International Federation for management of thalassemia, because initially it was just management of thalassemia, and then it divided into two books, one for non-transfusion dependent thalassemia and one for transfusion dependent thalassemia. So the first book which was there had this table. So I would just like you to look at certain things in this table for us to know that even before we knew that these are different entities. भाई वो कहाँ है जिससे point करती है? If you look at this column, which is hemoglobin F, तनी आवाज़ आ रही है. If you look at thalassemia major, the F is more than 50%, right? Or 50% or maybe 40%. But if you look at this column, which is thalassemia intermedia, then the value of HbF has been mentioned in that book very early on. 10 to 50%, maybe up to 100%, which means that an intermedia patient can have a hemoglobin of even 100%. This is now an old publication. And then again, in this very table, there was this, that high HbF thalassemia could be present in one of the parents, trying to tell us the role of modifiers. In the same table, अच्छा एक चीज़ और भी mention करनी चाहिए मुझे, and that is that in thalassemia major they said it should always present less than 2 years, and in thalassemia intermedia it should always present more than 2 years. But I will tell you that you can present less than 2 years, you can present up to 100%, and you will be intermedia. So, these are the guidelines. When it comes to the patient, then you have to see what you are dealing with. This is again, they have just said that in this they only mention XMN1 polymorphism, which would be present in thalassemia intermedia. But they do write here that this mutation would be severe in thalassemia major, and mutation will be mild or silent in thalassemia intermedia, as I earlier said. So because of that reason, this in Thailand, since we learned in the morning that in Southeast Asia, alpha thalassemia is more common. So in Thailand University, because they had a lot of alpha thalassemia, they devised a scoring system to detect their patients. And this was called Mahidol scoring. Mahidol scoring has various parameters like steady state hemoglobin, and this is the value and this is the score. If the child has a steady state hemoglobin of more than 7, then he will score 0. If he has a hemoglobin of 6 to 7, he will score 1. And less than 6, the score will be 2. So it is important for us because in the end, we will make a calculation according to the scoring. Age at onset, more than 10, 0, 2 to 10 years, half, and less than 2 years, 1. So the possibility of intermedia is not absent less than 1, it is still there. age at first transfusion more than 10 years 0, but he could have received a transfusion at 4 years. So 4 to 10, 1, and less than 4, 2 scores. Like this, there is a requirement for transfusion. None is 0, occasional is 1, and a regular blood transfusion scheme is 2. And here I must just caution you that a child may not be requiring a regular blood transfusion, but what happens in our country is that once you have a report which says you are thalassemia intermedia, and that patient goes to a NGO who's giving blood, so they give blood regardless of the hemoglobin or the requirement. So they go on a monthly transfusions, not that they require it, but they just are on that. So you will have to find out that why he's getting irregular blood transfusion. Size of spleen is very important, and in my practice, the most important thing in monitoring thalassemia intermedia is size of spleen. If the size of spleen is less than 4, the score is 0, 4 to 10 is 1, and less than 10 is 2. So growth retardation could be plus minus here, none, 0, plus minus half. So what is done is then after having seen all this, which does not take a lot of time, then you take the total score. If the score is mild, 4, less than 4, then it's a mild disease. If the score is 4 to 7, then it's a moderate disease. And if the score is 7, more than 7, then it is severe disease. So what do you, when I say it's a mild disease or a moderate disease or a severe disease, what do you think will happen to the child? Anybody? माइल्ड में तो होगी ही नहीं, अनलेस एंड अनटिल उसको कोई इस तरह की ज़रूरत पड़े कि उसको कोई एक्यूट इन्फेक्शन हो, उसका कहीं ब्लड लॉस हो, ठीक है, या अगर वो अडल्ट पेशेंट है तो उसमें प्रेगनेंसी हो, या कोई उसका सर्जिकल प्रोसीजर हो जिसमें ब्लड लॉस हो, ठीक है. मॉडरेट में क्या होगा? मॉडरेट में ओकेजनल ट्रांसफ्यूजन लगती है, और उस ओकेजनल ट्रांसफ्यूजन का ताल्लुक भी ये जो पीछे मैंने चीज़ें मेंशन की हैं इनके साथ, और बच्चों में ग्रोथ स्पर्ट के साथ. जब बच्चों का ग्रोथ स्पर्ट आता है उस वक़्त बाज़ औक़ात इनको देनी पड़ती है, या अगर डिलेड प्यूबर्टी हो जाए तो फिर उनको देनी पड़ती है. और जो सीवियर डिजीज़ है उनको मोर और लेस यू विल हैव टू गिव देम रेगुलर ब्लड ट्रांसफ्यूजन्स. लेकिन यहाँ ये बताना ज़रूरी है कि अगर आपने एक टाइम पे किसी सीवियर डिज़ीज़ के पेशेंट को रेगुलर ब्लड ट्रांसफ्यूजन पे डाल भी दिया है तो बाज़ औक़ात ये पेशेंट्स जो होते हैं वो बाद में आप उनको हाइड्रोक्सी यूरिया पे स्विच कर सकते हैं, और जिनको आप मॉडरेट में हाइड्रोक्सी यूरिया देते रहते हैं उनको बाद में आपको रेगुलर ब्लड ट्रांसफ्यूजन पे बाज़ औक़ात जाना पड़ता है, और वो कब जाना पड़ता है वो हम देखेंगे. अच्छा जी, ये एक लास्ट लाइन, इस पे हमारी एक स्टडी हुई है, काफ़ी लंबी चौड़ी हमने की है, और हम कोशिश करेंगे आपके साथ कुछ थोड़ा सा शेयर करें. विच इज़ हीमोग्लोबिन 90 और मोर देन 90 इज़ ऑलमोस्ट ऑलवेज थैलेसीमिया इंटरमीडिया. ये बहुत ग्लेयरिंग सी बात है, लेकिन इसकी सपोर्ट में मैंने आपको पहले ही टेबल दिखा दी है कि वो टेबल जो है वो बहुत डिकेड्स पुरानी है, और उसमें भी ये मेंशन था कि हीमोग्लोबिन F जो है वो बहुत ज़्यादा हो सकती है. तो ये नहीं होता कि एक पेशेंट आए और उसकी HbF जो है वो 80% हो या 88 हो या 90 हो तो आप कहें ये थैलेसीमिया मेजर है, जबकि क्लिनिकली देखा नहीं होता मरीज़ हेमाटोलॉजिस्ट ने, और वो नीचे लिख देता है रिपोर्ट इज़ कंसिस्टेंट विद थैलेसीमिया मेजर. मगर आपकी ड्यूटी है मालूम करना कि रिपोर्ट जो है उसकी क्या है, और उसको कैसे करेंगे आप, उसकी हिस्ट्री, क्लिनिकल एग्जामिनेशन एंड माहिडॉल स्कोरिंग. माहिडॉल स्कोरिंग इज़ नॉट डिफ़िकल्ट, एक चार्ट बना के लगा लें जहाँ आप काम करते हैं, 2 मिनट में आपको पता लग जाएगा कि क्या हो रहा है. ओके, जहाँ तक once you have decided that a patient has thalassemia intermedia, how will you manage? Management में वही बातें हैं, blood transfusion भी करनी है, chelation भी करनी है, augmentation भी कर सकते हैं, और treatment of complications. क्योंकि complications की treatment जो होती है वो often आपका जो previous mode of treatment है उसको change करने का बायस बन जाता है. जैसे इन्होंने एक सवाल पूछा था ऑस्टियोपोरोसिस वाला, ठीक है, तो फिर चीज़ें चेंज करनी पड़ती हैं. इसी तरह से हम और भी आपको बताएंगे सिनेरियो जहाँ पे चेंज करना पड़ता है. और स्प्लीनेक्टमी करनी है नहीं करनी है, करने के क्या नुकसानात हैं, ये भी थैलेसीमिया इंटरमीडिया में डिफरेंट है. क्योंकि थैलेसीमिया इंटरमीडिया की कॉम्प्लिकेशंस आर लिंक्ड with the genetic makeup of that patient, whereas complications of thalassemia major are linked with the amount of iron which is present, the iron overload. उसमें complications iron overload से होती हैं, चाहे वो जिगर में चला जाए, चाहे वो हार्ट में चला जाए, चाहे वो एंडोक्राइन में चला जाए या बोन में चला जाए, ठीक है. लेकिन इंटरमीडिया में इनहेरेंट जेनेटिक जो इसकी कॉम्प्लिकेशंस हैं, आई विल कम टू दैट. जो इंटरनेशनल रिकमेंडेशंस हैं जो कि आपको उसमें मिल जाएंगी पब्लिकेशन में जो टिफ की है, वो ये है कि हीमोग्लोबिन लेवल शुड नॉट बी एन इंडिकेटर, ये एग्जैक्ट उनके लफ्ज़ हैं, फॉर इनिशिएशन ऑफ ट्रांसफ्यूजन थेरेपी एक्सेप्ट इन कंसिस्टेंटली सीवियर एनीमिया which is hemoglobin level less than 5 gram per deciliter. और वो ये कहते हैं कि जब थैलेसीमिया इंटरमीडिया का पेशेंट का HB 6.5 पे आ जाए तो फिर आप उसको ट्रांसफ्यूज़ करें, ठीक है. और वो ये कहते हैं कि अगर आपने किसी पेशेंट को रेगुलर ब्लड ट्रांसफ्यूजन्स पे डालना है, जैसे आप थैलेसीमिया मेजर में डालते हैं, तो उसके लिए आपको काफ़ी महीने उस पेशेंट को फॉलो करना चाहिए. ये इंटरनेशनल रिकमेंडेशन है, लेकिन आई होप वी ऑल अंडरस्टैंड कि जो गाइडलाइंस होती हैं इंटरनेशनल, ये कुरान के सहीफ़े नहीं होते, ठीक है. इनको हम अपने हालात के मुताबिक और अपनी पॉपुलेशन के मुताबिक हम उसको चेंज कर सकते हैं. चेंज क्यों करना पड़ता है? इसलिए करना पड़ता है कि अगर आपने उसको कहा कि भाई तुम्हारी जब हीमोग्लोबिन 6.5 पे होगी तो तुम आ जाना ब्लड लगवा लेना, तो वहाँ तो वो जो सेंटर होगा ना वो उसको फ़ोन करेगा तो वो मरीज़ आ जाएगा, वो ब्लड लगा लेगा, ठीक है. आपने यहाँ पे किसी को कह दिया कि भाई तुम 6.5 पे ब्लड लगा लेना, तो वो ना आएगा आपके पास जब उसकी हीमोग्लोबिन 3 होगी. आप उसको पूछेंगे भैया ये क्या किया? उसने कहा जी कि वो पहले तो वो साढ़े उत्थे एक हकीका आ गया, उत्थे चले गए साथ, फिर मंगनी होगी मेरी भैन की, तो उत्थे चले गए साथ, फिर लै हो गया, तो वो आया आपके पास 3 ग्राम. तो इसलिए मैंने ये सोचा कि हमें अपने मुल्क के मुताबिक चीज़ें करनी चाहिए. तो उसमें फिर ये है कि ये जो 5 ग्राम है ये मैं देती हूँ अप टू 2 years of age, बिकॉज स्मॉलर चिल्ड्रन दे डू बेटर, ठीक है, स्पेशली इफ़ दे हैव ए हाई HbF, क्योंकि वो जो हाई HbF होती है ना वो अल्फ़ा वालों के साथ मिलके ना जोड़े बना लेती है, ठीक है. 2 से लेके और 5 साल तक फिर मैं उसको 6.5 कर देती हूँ. 5 साल से लेके 10 साल तक मैं उसको 7 कर देती हूँ. 10 से 12-13 साल तक मैं उसको 7.5 और एडल्ट पेशेंट्स को मैं 8 देती हूँ. क्योंकि अगर जब आप ज़्यादा से ज़्यादा थैलेसीमिया के मरीज़ों को देखेंगे तो आपको ये पता लगेगा कि एक एडल्ट होता है ना, चाहे वो मेल हो चाहे फीमेल हो, उसकी 10 ग्राम पे अच्छी एक फंक्शनिंग होती है. हमारे बहुत से जनरल पॉपुलेशन में भी लोगों की HB तो 10 ही होती है ना, स्पेशली फीमेल्स की, ठीक है ना, लेकिन उससे कम पे ना वो थोड़ा सफ़र करते हैं. तो जो 8 का कट ऑफ आप देंगे ना तो वो 8 पे ब्लड लगा लेगा ना, तो उसकी मीन हीमोग्लोबिन 10 ही आ जाएगी, समझ गए. تو آپ نے اپنے پیشنٹ کی ایج کے مطابق. اور ایک اور چیز جو امپورٹنٹ ہے جو میں کور کروں گی کہ سائز آف اسپلین. اگر ایک پیشنٹ ہے اس کو آپ نے 7 گرام کا کٹ آف دیا ہوا ہے اور وہ سال کے بعد آپ کے پاس آتا ہے, تو پہلے اس کا جب آپ نے ایگزامن کیا تو اس کی اسپلین 3 سینٹی میٹر تھی, اور جب وہ سال کے بعد آپ کے پاس آیا, کیونکہ وہ ریگولرلی آپ کے پاس نہیں آیا, اور اس کی اسپلین 7 ہو گئی, تو آپ نے پھر فوراً سوچنا کہ اوہو میں نے کیا کرنا ہے, میں نے کٹ آف تھوڑی دیر کے لیے ہائی کرنا ہے, اس اسپلین کو واپس بھیجنا ہے. کیونکہ تھیلیسیمیا انٹرمیڈیا میں اسپلینیکٹمی کا نقصان بہت زیادہ ہے. تھیلیسیمیا انٹرمیڈیا میں اسپلینیکٹمی کے 8 ایئرس پوسٹ اسپلینیکٹمی کمپلیکیشنز بہت زیادہ ہیں, تو وہاں ہمیں اسپلین کے بارے میں بہت کانشیس رہنا پڑتا ہے. اگر کسی مریض میں, کیونکہ وہ ماہیڈول کا سکور جو ہے وہ 7 سے زیادہ ہے, یا آپ نے کسی کمپلیکیشن کی وجہ سے جو تھیلیسیمیا کی انہیرنٹ ہیں, 5 کمپلیکیشنز میں آپ کو بتاؤں گی, وہ اس کے ساتھ آپ کے پاس پہلی دفعہ آیا ہے اور آپ نے ڈیسائیڈ کر لیا کہ نہیں یہ والا جو مریض ہے اس کو تو میں ریگولر بلڈ ٹرانسفیوژن ہی دوں گی, تو پھر اس کا جو ریجیمن ہوگا وہ وہی ہوگا جو تھیلیسیمیا میجر کا ہوتا ہے. یعنی کہ آپ اس کی پری ٹرانسفیوژن ہیموگلوبن کتنی رکھیں گے؟ 9.5. ٹھیک ہے, 10 والی جو ہوتی ہے وہ ہائپر سیچوریشن اس میں چلی جاتی ہے, وہ ہم نہیں اتنا کرتے. ہمارے ملک میں لوگوں کی ویسے ہی ایچ بی کم ہی ہوتی ہے. اوکے, وین اٹ کمس ٹو تھیلیسیمیا انٹرمیڈیا یو مے ریکوائر این اوکیجنل بلڈ ٹرانسفیوژن. اب یہ ڈفرینٹ اس کے ایریاز ہیں, یہ ساری انٹرنیشنل گائیڈ لائنس کے مطابق ہیں. اینٹیسپیٹڈ ایکیوٹ اسٹریس, لائک آئی ارلیئر سیڈ کہ اس میں کیا چیزیں آ جائیں گی, اس میں آپ کی آ جائے گی کبھی تو یہ ٹھیک جل جاتا ہے کبھی نہیں جلتا, پریگنینسی, سرجری, انفیکشن اور ٹراما. یہ اس کے آپ کو ہو سکتا ہے اس موقع کے اوپر بلڈ لگانا پڑے. کبھی کبھی ہمیں زیادہ دفعہ بلڈ لگانا پڑتا ہے, اور وہ کس طرح سے ہمیں لگانا پڑے گا. یہاں پہ آئی ٹولڈ یو دیٹ if the splenomegaly is at a rate exceeding 3 centimeter per year, right, اور میکسیمل گروتھ اینڈ ڈیولپمنٹ کا پیریڈ ہے, جبکہ بچوں کی ایک دم سے زیادہ ہائٹ بڑھتی ہے یا پیوبرٹی آتی ہے, یا اس پیشنٹ میں کنسسٹنٹلی جو ہائٹ اور ویٹ ہے وہ امپروو نہیں کر رہے, پھر بھی آپ کو اوکیجنلی لگانا پڑتا ہے. یا اگر کوئی پیرنٹس آ کے کمپلین کریں کہ جی اسکول میں اس کی پرفارمنس اچھی نہیں. ڈیمینشڈ ایکسرسائز ٹالرنس, اور ڈیمینشڈ ایکسرسائز ٹالرنس عام طور پہ ایڈلٹس میں آ کے کمپلین کرتے ہیں. کچھ بچے بھی 9-10 سال کے بعد کمپلین کرتے ہیں کہ ہم, یا مائیں کہتی ہیں کہ یہ نا اسکول کا بیگ اٹھا کے نا سیڑھیاں نہیں چڑھ سکتا, اس کی کلاس اوپر کی منزل میں ہے. ٹھیک ہے, کیونکہ ہمارے تو بیگ ہی بڑے بھاری ہیں نا, ان کے اندر تو ویسے کچھ نہیں ہوتا لیکن ان کا وزن زیادہ ہوتا ہے. تو فیلئر آف سیکنڈری سیکشول ڈیولپمنٹ, بونی چینجز جو ہیں یہ آئیڈیلی بہت امپورٹنٹ ہے. ٹھیک ہے جی, کہ کسی کی شکل جو ہے وہ بری نہ لگے. میرے لیے بڑا یوزفل ہے. آپ آؤٹ ڈور میں بیٹھے ہیں, ایک پیشنٹ آیا ہے, اس کو بونی چینجز ہیں, ادھر ہی شک ڈال دیں یہ تھیلیسیمیا انٹرمیڈیا ہے. لیکن اس کے ساتھ ہی ایک اور بچہ انٹر ہوا, اس کی شکل خراب نہیں ہے, اس کے یہ بھی نہیں نکلے ہوئے, اس کے یہ بھی نہیں خراب, اس کا یہ جو بھی نہیں ہوا ہے, وہ جو ہے نا وہ میجر ہے. اب آج کے بعد آپ اپنے آؤٹ ڈور میں ذرا دیکھنا شروع کر دیں, آپ کو پتہ لگے گا کہ جن کے اسکیلیٹل فیچرز آ جاتے ہیں وہ عام طور پہ انٹرمیڈیا ہی ہوتے ہیں, اور جن کے نہیں ہوتے وہ میجر ہوتے ہیں. اس کی وجہ یہ ہے کہ میجر بیچارہ تو ڈپینڈنٹ ہے نا بلڈ لگانے پہ, اس کے بیچارے کا جیسے ہی انیمیا ہوگا وہ بھاگے گا جا کے خون لگوا لے گا, تو بونس کو تو ٹائم ہی نہیں ملے گا ایکسپینڈ کرنے کا میڈلری اسپیس کو کہ وہ آئے. لیکن انٹرمیڈیا میں کیا ہوگا, وہ تو خوش ہے, اس کی 6.5 پہ بھی خوش ہے, 7 ग्राम पे भी खुश है वो तो आएगा नहीं ना, जैसे डॉक्टर साहब ने कहा था 2 साल के बाद आ जाता है, इसलिए कि वो खुश है, उसको इतना प्रॉब्लम नहीं है, ना उसको एफर्ट इंटॉलरेंस है, ना उसकी किसी ने P2 सुनी है, ना उसकी किसी ने स्प्लीन देखी है, ना उसकी किसी ने हड्डी को हाथ दबा के देखा है कि इसको दर्द है कि नहीं, तो वो नहीं आएगा, लिहाजा ही विल डेवलप द फेशीज़। तो वो जो पुरानी किताब में तस्वीर थी ना कि थैलेसीमिक फेशीज़, वो एक्चुअली थैलेसीमिक फेशीज़ इंटरमीडिया में होती है, मेजर में नहीं होती। मेजर वाले को तो ब्लड नहीं लगेगा तो फौत हो जाएगा, आपको पता लगेगा ओ जी साढ़े खानदान पहले कदी नहीं सी थैलेसीमिया, मेरा जड़ा पिछला बच्चा सी ना उन्हें 5 महीनों ते नमूनिया होया, असी अस्पताल गए, उन्होंने कहा HB बहुत घट है, तुसी खून का इंतज़ाम करो, असी भजे दौड़े, असी खून लैके आए, खून लगा भी नहीं, साड़ा बच्चा फौत हो गया। अब ये जो स्टोरी है ना, ये थैलेसीमिया मेजर है, ठीक है, because you should understand that that child had thalassemia major and he died because he did not get blood at the right time, क्योंकि acute infections lower the hemoglobin very quickly, especially if they are with organisms which produce hemolysins, right? So that is about the that thing. ये हम शायद पिछली स्लाइड पे थे, ये मैंने कर दिया। पुअर क्वालिटी ऑफ लाइफ, दैट इज़ ऑल्सो एन इंडिकेशन। अच्छा, कुछ चीज़ों में वो कहते हैं कि प्राइमरी या सेकेंडरी प्रिवेंशन करने के लिए हमें थैलेसीमिया इंटरमीडिया में ब्लड लगाना पड़ता है। वो मैंने आपको पहले ही कहा था कि जो कॉम्प्लिकेशंस अगर होंगी ना, तो आपके मैं एक पेशेंट है, आपने उसको 3, 4, 5 साल हाइड्रोक्सी यूरिया पे मैनेज कर लिया, लेकिन अब वो आया है तो उसको, क्योंकि इन पेशेंट्स में होता है थ्रोम्बोफिलिया। थ्रोम्बोफिलिया इनमें क्यों होता है? इसलिए कि इनकी RBC की मेम्ब्रेन और प्लेटलेट्स की जो मेम्ब्रेन होती है वो डिफेक्टिव होती है, उसमें इंक्रीज्ड एडहेसिवनेस की क्वालिटी होती है, इसलिए इनमें थ्रोम्बोफिलिया होता है। तो जो थ्रोम्बोफिलिया होता है उससे फिर थ्रोम्बोसिस और थ्रोम्बो एम्बोलिक फिनोमेना। एक पेशेंट बहुत साल पहले मैंने देखा था, शायद पता नहीं ताहिर उस वक्त था कि नहीं सेंटर में, हमारे पास एक पेशेंट था जो रेगुलरली ब्लड ट्रांसफ्यूज़ कराता था, और फिर एक दिन वो आया काफ़ी दिनों बाद, तो मैंने कहा भाई तुम इतनी देर के बाद क्यों आई? तो उसने कहा इन्हों जी फालज का अटैक हो गया सी, और ही हैड कम विद CVA, याद है, उसका हीमिप्लीजिया। तो what at that particular time we had missed when he was a young boy and I was not so old, we missed that he had thalassemia intermedia. So they can come with thromboembolic phenomena. They can also come with pulmonary hypertension. और pulmonary hypertension का क्या है कि ये कोई इतना मुश्किल काम नहीं है पिकअप करना। थैलेसीमिया इंटरमीडिया का मरीज़ मैं आउटडोर करती हूँ बुध वाले दिन, 2-3 चीज़ें देखती हूँ, शक्ल देखती हूँ, वैसे और आपके जैसे बहुत से मेरे मेहरबान होते हैं जो कि सारा कुछ देख लेते हैं ना, मैंने ज़्यादा नहीं देखना होता, जब आप ज़्यादा बूढ़े हो जाते हैं आप कम हिलते हैं, तो मैंने 2-3 चीज़ें देखनी होती हैं, उसमें एक होता है P2, मैं ज़रूर सुनती हूँ, P2 एंड ए मर्मर ऑफ ट्राइकस्पिड रीगर्ज, बिकॉज दैट टेल्स मी कि ये जो है ना बच्चा, इसने अब पल्मरी हाइपरटेंशन डेवलप कर लिया। और दूसरी चीज़ देखती हूँ स्प्लीन, और जब मैं स्प्लीन को देखती हूँ ना तो मैं उसको ज़रा सा हाथ लगा के ज़रूर देखती हूँ कि नरम है कि सख्त है। अगर तो नरम है तो फिर तो उसको अभी रिसेंट हार्ट फेलियर हुआ है तो उसकी वजह से है, या कोई इन्फेक्शन है तो वो तो वापस चली जाएगी, लेकिन अगर वो हार्ड हो गई है तो इसका मतलब वो वापस नहीं जाएगी, इसको फिर हमें अल्टीमेटली निकालना ही पड़ेगा। तो फिर हमें क्या करना पड़ेगा, हमें अपना कट ऑफ चेंज करना पड़ेगा, ठीक है। सो दिस इज़ हाउ दीज कॉम्प्लिकेशंस चेंज द वे यू ट्रीट अ पेशेंट, राइट। एक्स्ट्रा मेडुलरी हेमोपोइसिस, उसमें कोई चॉइस ही नहीं है, आपको कुछ अरसे के लिए उसमें आपको हाइड्रोक्सी यूरिया भी देना पड़ेगा और ब्लड ट्रांसफ्यूजन्स भी देनी पड़ेंगी जब तक कि वो रिग्रेस नहीं कर जाता, बिकॉज हमारे पास ये फैसिलिटी नहीं है कि हम उस जो ट्यूमर है उसको रेडिएट कर लें। باہر کے ملکوں میں ان کے پاس فیسلٹی ہے, وہ اس کو ریڈیٹ کر لیتے ہیں, تو وہ ٹیومر جو ہوتا ہے وہ شرنک کر جاتا ہے یا ڈس اپیئر ہو جاتا ہے, رائٹ. لیگ السرس, تھیلیسیمیا انٹرمیڈیا کے پیشنٹ میں you should always examine the medial and the lateral malleoli and look at them carefully if they are discolored. If they are discolored, again you understand that they are ischemic ulcers. In these patients they develop ischemic ulcers around there. So agar uski discoloration ho gayi hai, you will have to change your cutoffs. And you may have to put them on hydroxyurea, even if you had them on a regular blood transfusion. So that is another complications. And silent brain infarcts. اب silent brain infarcts, اب یہ جو ہے فیسلٹی یہ بہت کم سینٹرز میں اویلیبل ہے. ہمارے لاہور میں بھی 2-3 ہی ریڈیولوجسٹ ہیں جن کو ہم کرینیل بھیج دیتے ہیں الٹرا ساؤنڈ کے لیے کہ وہ مڈل سیریبرل آرٹری کا ہمیں کوئی فلو بتا دیں. تو وہ جو کرتے ہیں نا گائنی میں اس کا ایس ٹی ریشو وغیرہ نکالتے ہیں, وہ والے جو ریڈیولوجسٹ ہوتے ہیں وہ ادھر بھی کر کے ہمیں بتا دیتے ہیں. تو اس کا تعلق اس کی ویلاسٹی سے ہوتا ہے جو مڈل سیریبرل آرٹری میں ہوتی ہے, اس سے ہوتا ہے. تو وہ ہمیں کر دیتے ہیں تو ہمیں پتہ لگ جاتا ہے, ادروائز ہمیں نہیں پتہ لگتا. اچھا, یہ تھیں وہ ساری باتیں جو میں نے آپ سے کہا کہ ڈیسائیڈ کرتی ہیں کہ آپ نے بلڈ ٹرانسفیوژن کس طرح دینی ہے. دینی ہی نہیں ہے, کم دینی ہے, زیادہ دینی ہے, ریگولر رکھنا ہے, یا آپ نے چینج کرنا ہے. اور چینج کرنے کا بھی میں نے آپ کو بتا دیا کہ ڈفرینٹ چیزیں. اچھا, اب یہاں میں رک جاتی ہوں اور آپ کے سوال لے لیتی ہوں کیونکہ پھر بعد میں نا آپ کے مشکل پڑتی ہے. یہاں پہ اس کو حل کر لیتے ہیں بلڈ ٹرانسفیوژن والے کو, پھر آگے چلیں گے. جی, any questions on that? جی جی.
Ma'am, a patient came to us at 7 years of age for the first time, اور اس سے پہلے اس نے کبھی ٹرانسفیوز نہیں کرایا تھا, اور پھر یہ اس کو ہوا تھا پورٹل وین تھرومبوسس. پھر ہم نے اس کو ہائیڈریا وغیرہ پہ ڈالا اور سارا کچھ, اور اینٹی تھرومبوٹک تھراپی. لیکن اس کے اب ہم جو ہے ٹرانسفیوژن کو ہم ریگولر کر دیں گے یا مطلب ایٹ دس پوائنٹ, یا اس کا کیا پلان ہونا چاہیے فار ٹرانسفیوژن؟
چلیں وہ تو میں آپ کو بتاتی ہوں ابھی, لیکن فار دی بینیفٹ آف دا ریسٹ آف دا پارٹیسپینٹس آپ مجھے اس کی کلینکل پکچر بتائیں, بیکاز پورٹل وین تھرومبوسس کی بڑی اچھی سی خوبصورت سی ہسٹری ہوتی ہے. بتائیے.
میم یہ آیا تھا اس کے فیشیز تھے ایکٹوٹیپیکل سے.
نہیں, فائنڈنگس جو ایبڈومن کو کیا تھی, کیا اس نے کمپلین کیا کیا؟ نہیں, پین کی کمپلین نہیں تھی, ایبڈومنل پین. The first complaint they have with thrombosis of portal vein is pain abdomen, and the second she said ascites, and the third I tell you jaundice. So unfortunately چونکہ jaundice بھی ہوتا ہے, pain abdomen بھی ہوتا ہے, اور portal vein very near to liver, right? تو پہلے تو اس کو بیچارے کو ہیپاٹائٹس اے بی کی ٹریٹمنٹ ملتی رہتی ہے, بیچارہ وہ تڑپتا رہتا ہے پین سے, اور اس کے بعد بڑا لیٹ آتا ہے. ٹھیک ہے. So abdominal pain in thalassemia is a very important symptom جس کی بہت ساری. abdominal pain آپ کو portal vein thrombosis سے بھی ہوتی ہے, آپ کو ہارٹ فیلئر سے بھی ہوتی ہے, آپ کو tricuspid regurg سے بھی ہوتی ہے, pulmonary hypertension سے بھی ہوتی ہے, gall stones سے بھی ہوتی ہے, renal stones سے بھی ہوتی ہے. ٹھیک ہے. تو یہ بڑی ایسی چیز ہے جس کو آپ نے نگلیکٹ نہیں کرنا ہوتا. تو اب میں اس کے سوال کا جواب دیتی ہوں جو اس نے میرے سے کیا. اس میں یہ ہے کہ پورٹل وین تھرومبوسس کے پیشنٹس کو آپ انیشیلی تو وہی اینٹی کویگولنٹ, اینٹی ایگریگیٹ تھراپی دیتے ہیں, اور اس کے بعد آپ اس کو اوکیجنل بلڈ ٹرانسفیوژن میں تھیلیسیمیا کے یہ ہائیڈروکسی یوریا کے اوپر ڈال دیتے ہیں. ٹھیک ہے. دیٹ از ہاؤ یو شوڈ مینیج. لیکن جیسے پورٹل وین تھرومبوسس ہوا تو آپ کو سمجھ آ گئی کہ کیوں بیسیکلی انٹرمیڈیا ہے, کیونکہ اس میں تھرومبوفیلیا تھا. ٹھیک ہے. تو اس کی بیسک پھر وہ جو ہے آگمنٹیشن آف گاما چین. ٹھیک ہے.
اس کا پھر ہم نے یہ پلان کیا تھا کہ 6.5 to 7
ایج آپ نے 8 سال بتائی ہے, 7 سال, 6 سال, 6.5, 7 سال, 8 سال کا, ہاں 8 7 رکھیں, 7 رکھیں, ٹھیک ہے, تو یہ کریں اس کے ساتھ. اینی ادر کوشچن بیٹا؟ کوئی تو مریض آیا ہوگا آپ لوگوں کے پاس کسی سینیریو کے ساتھ جس میں کوئی ہیلپ چاہیے ہوگی, نہیں؟ ہاں جی بولیں جی. آپ کے پاس تھا. لیگ السرز کی ٹریٹمنٹ جو ہوتی ہے وہ بھی ہائیڈروکسی یوریا دیتے ہیں, اور آپ اپنا کٹ آف چینج کرتے ہیں, اور چونکہ ایک کمپلیکیشن آ جائے گی, یہ رول ہے تھیلیسیمیا میجر اور انٹرمیڈیا میں, اف دیر از ون کمپلیکیشن, لائک ایک پیشنٹ ہے تھیلیسیمیا میجر کا, اس میں ہائپوتھائرائڈزم آ گیا, ساری اینڈوکرائنوپیتھیز کو انویسٹیگیٹ کرو, ٹھیک ہے. اسی طرح سے تھیلیسیمیا میجر انٹرمیڈیا میں ایک کمپلیکیشن آ گئی ہے, باقی ساروں کے لیے انویسٹیگیٹ کرو, ٹھیک ہے, مت چھوڑو. پھر اس کا مسٹ ہے کہ اس کا آپ نے ڈیکسا بھی کرانا ہے, اس کا آپ نے ایکو بھی کرانا ہے, دیکھنے کے لیے کہ باقی چیزیں نہیں کیا ہیں, اور آپ نے اس کا وہ بھی کرانا ہے, آپ نے اس کا RBC کاؤنٹ بھی دیکھنا ہے, آپ نے اس کا پلیٹلیٹ کاؤنٹ بھی دیکھنا ہے, دیکھنے کے لیے کہ یہ تھرومبوفیلک ہے کہ نہیں, ٹھیک ہے. اچھا, تو اس میں دیتے ہیں ہائیڈروکسی یوریا ود انکریزڈ لیول آف کٹ آف لیول آف ہیموگلوبن, اور پیشنٹ کو کہتے ہیں کہ رات کو سوتے وقت وہ اپنے پیر جو ہیں ان کو ان کے نیچے تکیہ رکھے تاکہ تھوڑا سا وہ ریزڈ رہیں, ٹھیک ہے. اگر اوپن السرز ہوں تو پھر ان کی ٹریٹمنٹ جیسے ٹروفک السرز کی ہوتی ہے اس طرح سے کرتے ہیں, ٹھیک ہے. اینی ادر کوشچن؟ سر تو کہہ رہے تھے کہ بچوں نے بہت سارے سوال پوچھنے, تو بچے تو سوں گے نہیں. اچھا چلو کوئی گل نہیں. لیٹس ڈو دی چلیشن ان تھیلیسیمیا انٹرمیڈیا. اچھا, تھیلیسیمیا انٹرمیڈیا ڈفرس فرام تھیلیسیمیا میجر in one aspect, that in thalassemia major the serum ferritin is linearly related to iron in the heart. So thalassemia major, high serum ferritin at which you are suspicious, to echocardiography for left heart function, right? In thalassemia intermedia, the serum ferritin is related to liver iron, and also in thalassemia intermedia the iron is patchy. اس میں نا چھوٹے چھوٹے نوڈیول جگہ جگہ بنے ہوتے ہیں, ٹھیک ہے. آپ لوگوں نے جنہوں نے مریض دیکھے ہوئے ہیں آپ کو پتہ ہوگا کہ تھیلیسیمیا انٹرمیڈیا کے پیشنٹس جب آپ کے پاس آتے ہیں ان کی سپلین اتنی نہیں بڑی ہوتی کئیوں کی جتنا ان کا لیور بڑا ہوا ہوتا ہے. اس کی وجہ یہ ہوتی ہے کہ وہ چلیٹڈ نہیں ہوتے ہیں جب وہ اولڈر ایج میں آتے ہیں, تو ان کی سیرم فیریٹین کی وجہ سے جو کہ لیور میں ڈپازٹ ہو رہی ہے, تو لیور میں فائبروسس ہو کے لیور کی ڈیمیج ہو کے لیور زیادہ بڑھ جاتا ہے. تو ایک تو یہ ہے کہ میجر پیشنٹ MRI ہارٹ, انٹرمیڈیا پیشنٹ MRI لیور, ٹھیک ہے. اور جو لک ہے اس کی ویلیو اس میں بہت ہے میجر میں, کیونکہ لک کی ویلیو جو ہے, یا جو آپ کرتے ہیں لیور کا اسکین ایک یہاں ہوتا ہے مجھے پتہ ہے پنڈی اسلام آباد میں, تو وہ ہارٹ کے ساتھ اچھا ریلیٹ کرتا ہے, ٹھیک ہے. لیکن لیور کی جو لک ہے یہ نہیں کرتا کو ریلیٹ ویل, کیونکہ یہ نہیں پتا کہ آپ کی نیڈل جو ہے اس نے نوڈیول کو پکڑا ہے یا کہ ادھر ادھر پکڑا ہے, ٹھیک ہے. تو یہ امپورٹنٹ بات ہے. So liver MRI is important in thalassemia intermedia, and the cutoff for start of chelation is 800 nanogram per ml, ٹھیک ہے. اور the recommendation is to maintain the serum ferritin around 400, 400, 350, 300 اتنے پہ رکھیں آپ اس کو. یہ آپ کو پتہ ہے کہ یہ پیشنٹ جو ہوتے ہیں یہ بالکل لو سیرم فیریٹین پہ تو جاتے نہیں ہیں. لو سیرم فیریٹین میں کون سے پیشنٹس جاتے ہیں تھیلیسیمیا والی خاندانوں میں؟ کوئی تھیلیسیمیا مائنر کا پیشنٹ آئرن ڈیفیشینٹ ہو سکتا؟ دیکھیں کبھی کرائی سیرم فیریٹین؟ چلو کراؤ. Thalassemia minor کے patients should do normally quite well, right? They don't report to you. لیکن کبھی کبھی تھیلیسیمیا مائنر کا پیشنٹ آپ کے پاس آ جاتا ہے, اس کا انیمیا بہت زیادہ ہوتا ہے اور وہ کمپلین کر رہا ہوتا ہے, تو آپ اس کا سیرم فیریٹین کرائیں تو وہ 2-3 ہوتا ہے, ٹھیک ہے؟ تو کچھ سوچ سکتے ہیں آپ کہ اس کو کیا ہوتا ہوگا, کیوں ایسے ہوتا ہے؟ نہیں. اوکے, آپ کو پتہ ہونا چاہیے کہ آپ کے ملک میں ایک اینٹیٹی اور بھی ہے, اس کو کہتے ہیں آئرن ریفریکٹری انیمیا یا IRA, ٹھیک ہے؟ IRA کی طرح بہت سے پیشنٹ بیہیو کرتے ہیں جو تھیلیسیمیا انٹرمیڈیا ہوتے ہیں. اب اس میں صرف آپ کو بتانے کا مقصد یہ ہے کہ یہ کئی دفعہ تھیلیسیمیا کے جو پیشنٹس ہوتے ہیں نا, ان کی مائیں آ جاتی ہیں, ٹھیک ہے؟ تو یہ جو پیشنٹس ہوتے ہیں نا, یہ صرف انجیکٹیبل آئرن کو رسپونڈ کرتے ہیں, اورل کو نہیں کرتے. اور اگر وہ تھیلیسیمیا مائنر نہ بھی ہوں اور IRA ہوں تو وہ صرف انجیکٹیبل آئرن کو رسپونڈ کرتے ہیں, اورل کو نہیں کرتے. چلو یہ تو ویسے ہی میں نے بتا دیا. اچھا جی, آگمنٹیشن آف فیٹل ہیموگلوبن ہم نے کہاں کہاں کرنی ہے؟ ایک تو یہی جو میں نے آپ سے کہا تھا کہ XMN1 پالیمارفزم کا بہت ہے, لیکن ادر SNPs جو ہے وہ روٹینلی لوگ نہیں کرتے, جبکہ the other SNPs are more common in thalassemia intermedia, which can tell you that this patient can respond to a response with hydroxyurea. پھر اس کے بعد یہ جو اسپیشل تھیلیسیمیاز ہیں, ان میں رول ہے ہائیڈروکسی یورک. ایلو ایمونائزڈ میں بہت جان بچتی ہے if you put them on hydroxyurea, because ایلو ایمونائزیشن ٹو اسٹارٹ ود, اور پھر اس کے بعد آٹو ہیمالسس شروع ہو جاتا ہے. اور ایلو ایمونائزیشن اور آٹو ہیمالسس والے جو پیشنٹ ہوتے ہیں, دے آر اے پین ان دا نیک اینڈ دے ٹیک months and sometimes years to resolve. تو وہاں پہ ہائیڈروکسی یوریا بہت یوزفل ہو جاتا ہے ود اسٹیرائڈس اور ود امیونوسپریسنٹس. وہ تو میں نے کہہ دیا نا, وہ تو تبھی. ہاں, ایک یہ ہو سکتا ہے کہ کومز ٹیسٹ کے ذریعے آپ کراس میچنگ کر کے لگا لیں, لیکن کوئی اس سے بہتر چیز. ارے بھائی بتایا تو تھا کہ ایلو ایمونائزیشن کیسے مینیج کرنی ہے, اس کو اسٹیرائڈس دینے ہیں اور ہائیڈروکسی یوریا دینی ہے. اب کیا کرے گا ہائیڈروکسی یوریا اس کے ساتھ؟ کچھ نہیں کرے گا, کیونکہ وہ 23 ویکس تو ہو گئے ہوئے ہیں, آرگینوجینیسس تو شروع ہو چکا ہوا ہے. اب کیا ایسی بات ہے, اب اس کو اس پہ ڈالو اور پھر اس کو کھینچو. کم از کم 28 ہفتے تو ہو جائے نا, 30 ہفتے تو ہو جائے نا. تو پھر آبسٹریٹیشن کو کہنا کہ اب تم نکال دو, میں ICU میں بھیج دوں گی. ٹھیک ہو گیا؟ اچھا, اب اور کسی کے ذہن میں کوئی اگر کوئی سینیریو ہے تو مجھے بتاؤ. میں نے جو امپورٹنٹ سمجھے تھے وہ تو میں بتا دیا. ٹھیک ہے, اوکے جی, تھینک یو ویری مچ.
ٹھیک ہے, ٹھیک ہے. ابھی آن کیوں نہیں ہے؟
Thank you, ma'am, for clarifying the concepts.
پریس کیا ہوا ہے, کیا پریس کر دیا ہے یار؟ ادھر سے وہ لڑکا نہیں ہے, آپ ہی کو.
میں کہاں سے کروں, آپ نے بلایا. میم یہ اندر والا لڑکا کہاں گیا؟
وہ ادھر میٹنگ شروع ہے, ایک رفڑ تو نہیں ہے ہمارے لیے. ایک ختم کر کے وہ لڑکا ہے, وہ مانگا ہے ادھر سے لیکچر ہال سے. پتہ یہ سارا سسٹم لگا ہوا, چھیڑنے کی ضرورت ہی نہیں.
کوئی نہیں چھیڑا, کیا ہو گیا؟ یہ بند کہاں سے ہوئی؟
یہ دے رہے ہیں.
ٹھیک ہے.
وہ فسرائل سے ہو گئے.
I request Dr. Muhammad Naveed, Assistant Professor Pediatrics at University of Lahore, to please come to podium to discuss the significance and application of Mahidol scoring system.
ये पॉइंटर है, ये छोटा सा दाना है, ये वाला। ठीक हो गया। ये दाएं बाएं अगर स्लाइड उधर से नहीं चलानी और उधर से चलानी।
ओके जी, बिस्मिल्लाहिर्रहमानिर्रहीम। इंट्रोडक्शन तो हो गया है, सो आई एम गोइंग टू highlight the important points of the study which we have done in Fatma Memorial with Professor Javeria, and that was the effectiveness of this Mahidol scoring, which Madam has already mentioned that this scoring system has been used in Thailand and the areas where the Thal-E is more prevalent. So this idea was floated by Professor Javeria that this Thal-E is one of the anti-DT and that is common in Thailand. So why we not use this scoring system in our setup and you assess the severity of thalassemia intermedia, which is more prevalent in our setup. So you are now familiar with the parameters which are used in the Mahidol scoring. There are 6 parameters. One is from the lab, which is steady state hemoglobin. 3 points from the history, which are the age of disease presentation, age of receiving the first blood transfusion, and requirement of the blood transfusion. And the 2 are on the examination, that is the spleen size and the growth and development, physical growth and development. And this is the scoring system which already Professor Javeria has mentioned. The total score is 7. And the interpretation of that is less than 4 is mild disease, between 4 to 7 is the moderate disease, and greater than 7 is the severe disease. So what we did, this study was done from August 2016 to August 2017, and in 2018 we sent for the publication in Journal of College of Physician and Surgeon Pakistan. March 2019 it was accepted for the publication and it was published in July 2019 in the same year. So 150 patients diagnosed as a thalassemia intermedia fulfilling the inclusion criteria were enrolled, interviewed and examined after informed consent. These patients were diagnosed thalassemia intermedia according to the international guideline. Prior to study they were taking either a hydroxyurea or blood transfusion, and they were on a regular follow-up in Fatma Memorial Hospital. The patient, those who have established endocrinopathy or cardiomyopathy were excluded from the study. And all the patients were assessed using the Mahidol scoring system. And apart from that, the other information was also gathered, which include the HB electrophoresis at the time of the diagnosis, their response to the hydroxyurea, and the change in frequency of the blood transfusion after the start of the hydroxyurea. And all these information were documented on a pre-designed evaluation performer. These patients were followed 3 and 6 monthly. So these were the results. Out of 150, 88 were male and 62 were females. And out of 150 cohort, the 88 patient has the mild disease, which is 59% of the total. The 53 has the moderate disease, which were 35% of the total, and 9 patients were with the severe disease, which is the 6% of the total. And this was the age of presentation in our study. The 50% of the patient, that was 76 in number, were present between 1 to 5 years of age. That was followed by the infancy. Those who were diagnosed during infancy were 44 in number, that was 29% of the cohort. 5 to 10 years, 19 patients were diagnosed, and that was 12.6%. And more than 10 years, 11 patients were diagnosed as a thalassemia intermedia, and they were 7.3% of the total. The important points in this study was the total 90 patients among 150 show the hemoglobin greater than steady state hemoglobin greater than 7 milligram, and out of this 90, 61 were fall into the mild group. That was 47% of the total. The blood requirement, 18 total patients were never been transfused before enrolled to us, and out of these 18, 16 were fall into the mild group. Once transfusion, the 12 patients were those who were only one transfusion, and 10% was 10 patient was falling in the mild group. The frequent transfusion, the total number of patients in the severe group was 9, and the 8 were having the frequent transfusion. Regarding the physical growth and development, the normal growth was seen in 68 patients, and out of this 68, 53 were fall into the mild group. The severe growth retardation was seen in 37, but the severe disease has only 9 patients, and 8 were severely growth retarded, and none of them fall has the normal growth pattern in the severe category. The splenic size less than 4 centimeter was found in 61 patients, and 44 were fall into the mild group. The response to the hydroxyurea, 85 patients show good response to the hydroxyurea, and 62 were fall into the mild group. The partial response was seen in 44 patients, and 23 were fall into the mild group. The change in blood transfusion, the majority of the patients which show the response, change in the blood transfusion, they fall into the mild group. And this is one of the other interesting point, that more than 90% or 70 to 90% of the hemoglobin that was also fall into the mild group. So on the basis of this, we conclude that this scoring system is very easy, safe and effective way for classification of thalassemia intermediate severity. Patients who were labeled as a mild disease had a less transfusion requirement and show good response to the hydroxyurea. Patients with the moderate score were infrequently transfused and show the variable response to the hydroxyurea, and the patient in the severe group received a first transfusion at an early stage, maintained lower hemoglobin levels, show growth retardation, splenomegaly, and had a poor response to the hydroxyurea. And so these grades will aid in the management of the patient, as the score can quickly calculated and can assist the clinician in the initial evaluation of the disease severity in a patient with thalassemia intermedia. To study the whole article, this link is available.
Thank you so much, sir, for your kind words. Now I request our worthy guest of honor, Major General Tasawwur Hussain, Hilal-e-Imtiaz Military Retired, Associate Dean, Clinical Sciences Foundation, University Medical College, and Fauji Foundation Hospital, Rawalpindi, for concluding remarks. Thank you, sir.
So I think I like to appreciate and commend the efforts of Brigadier Lodi for arranging this very useful activity. I'm very thankful to the guests who have come from the other hospitals and other cities and spared time and have educated us. I just managed to attend a part of it, and I found it very useful. One of my personal responsibilities as a teacher in medicine here is that I have to take the lecture on anemias. So I had a personal interest in knowing about this disease, and I think I've learned quite a lot. So I think we should have more activities like this. In spite of the situation in COVID, because we have to now learn to live with this, I think, for some time. And
I found it very useful, and I'm sure the audience must have learned a lot. And I once again thank all our guests and Professor Lodi for sparing time and participating in this activity. Thank you very much. Oh, that's okay.
To receive the shield, I now call upon stage Professor Dr. Javeria Manan. Professor Dr. Javeria Manan. Dr. Adil Akhtar, sir, can we please have you on stage too? On behalf of Dr. Adil Akhtar, Dr. Naveed is going to receive his shield. Dr. Adil Akhtar. Dr. Muhammad Naveed. Professor Dr. Muhammad Tahir. Dr. Muhammad Tahir. Dr. Kiran Mushtaq Tur. Dr. Munir Akmal Lodhi. Now, I request our Head of Department, Professor Brigadier Munir Akmal Lodhi, to present the shield to the guest of honor, Major General Tasawwur Hussain. This concludes today's session. Thank you all the worthy guests. I request you all to proceed for lunch to cafeteria.